transplant surgeon, lung transplant surgeon as well. And chairpersons for this session are Professor B. Mariappan and Dr. K. Manikandan. Can I welcome them? Please welcome, sir. So, please, sir.
Thank you for the warm introduction, Dr. Ellen. And good morning, everyone. It's an honor and a pleasure to be addressing in such an elite crowd of my seniors, teachers, friends, and colleagues. So I'm Dr. Premanand John, Senior Consultant at Gleneagles Hospital, Chennai. So just brush through basic concepts of lung transplantation and possibly like some modern advances. So this is a history of lung transplant. It started all off in 1963 when a patient got arrested and they did a left lung transplant. Patient didn't survive for more than 18 days. And then onwards from 1963 to 83, there was a little bit of hiatus. Not many transplants went on because of the poor outcomes. And about 36 transplants was done. And from 1981 onwards, there was a surge in transplants because of advances in immunosuppression and surgical protocols. So in March 9, 1981, there was the first successful heart-lung transplant, and subsequently in 1983 in Toronto, they did the first successful single lung transplant. And again in 1986, they did a successful double lung transplant, again in Toronto. So this is in a brief Indian history. The first combined heart-lung was done by Dr. K.M. Cherian in 1999. And the first successful single lung transplant was done by Dr. Madhushankar at Gleneagles Hospital, Chennai. And the first successful double lung transplant was done by Dr. Jnanesh Sakkar in 2012. Again in Gleneagles Hospital. So how common is lung transplants in current scenario is, in the year 2019, this data is taken from ISLT registry. ISLT is basically International Society of Heart and Lung Transplant. So by ISLT registry, the number of transplants that's been done from 1992 to 2018 is 68,000 transplants. And in the year 2019, they have done about 4,500 transplants. So the average is now is, in the last 3-4 years, is about 3,000 to 4,500 transplants keeps happening in the Western world, and across 260 centers in the world. So the number one country is United States of America, followed by European countries, and then China, and then India. So this is again the Indian data, like where the number of transplants from the year 2013 to 2022. You see there was a surge somewhere around 2019, 191 transplants. It was predominantly done in 2 centers. One is with Dr. KRB as the head, and the other one was Dr. Sandeep Patava. We were there together. And subsequently, there's a dip down during COVID, 67 transplants, and then again a rise there because of COVID indications. And this is a fantastic data. This is released in the official website of Transstan. So that shows that Tamil Nadu are the leaders of organ donation. And you can see the number of donors in a single year. Out of 365 days, there are 268 donors, which means an average is like, very good. And it far exceeds some of the Western standards. So Tamil Nadu really leads the way. And you can also see the government hospital participation, 146 donors in 365 days. And this year has actually gone up. There's a separate rule that's been made by the government saying that all non-transplant medical college hospitals have to report at least 1 donation in a month. So there are 36 plus 137 medical colleges in Tamil Nadu. So you're looking at an average of 15 to 20 donors easily a month. So there is a good inflow of organs and a very surprisingly low number of transplants done. And you can see that the organ utilization, the number of hearts and lungs are a little down. The other major organs will be liver and kidneys, which have been used in plenty. So I think it's time to buckle up and, cope up with the numbers. This is my experience from 2017, 2018 onwards actually. About 400 transplants, out of which 255 are lung transplants, and this number is not updated. And about 100 combined heart-lung 100 heart transplants and 45 combined heart-lung transplants. So what does the world say about the survival benefits? If you do a lung transplant, what is the median survival? You do a double lung transplant, the patient will have a median survival of 7.6 years. If you do a single lung transplant, the patient might live for 4.7 years. Not a very encouraging number, but this is the beginning of a greater science. So 85% of the population we operate survive for 1 year. You talk about 1 year survival, 3 year, 5 year and 10 year survivals for lungs. So it is slightly poor compared to heart and kidneys, 85% in 1 year and drops down to 59% in 3 and 5 years. So compared to kidneys, which is like still 90%, 70% in 5 and 10 years. So what makes it a little complex is, the scarcity. There's no scarcity of donors, but the scarcity of good quality organs makes it very complex. And again, the post-operative care is very challenging. You need a good team of pulmonologists, good team of anesthetists to take care. And there's a lot of challenges that happen during the first year, anastomotic complications, airway complications, which are very dreadful. So in spite of multiple challenges, lung transplant is a viable option for selected sets of patients in end-stage lung disease and always encourages an early referral. This is again the Western data where they have the topmost indication for a lung transplant is COPD, bronchiectasis or a destroyed lung, and comes alpha and antitrypsin deficiencies and cystic fibrosis and so on. And it is slightly the reverse in Indian scenario. This is our paper, our experience from 2017 to 2020, and further on we didn't have proper papers. So this paper, we have submitted data about 132 lung transplant patients. The key difference is in the indication. Our topmost indication is ILD, interstitial lung disease, followed by COPD and other things. So we don't do much of other cases actually. And this is again a slide to just show you the circulatory support. We have gone on ECMO, we've gone on CPB. And the best part of it is we did about 56 off-pump transplants in the year between 2018 and 2020. We were all so enthusiastic and then we thought off-pump transplants are easier because once the anastomosis is done, you close the chest and come because there's no bleeding, there's no CPB effects. But later on, we realized there's something called as PGD, primary graft dysfunction, was more with off-pump surgeries. So now it's a standard policy for the last 5 years that you have stopped doing anything on off-pump. We always use circulatory support, and the circulatory support we use is VA ECMO, not regular cardiopulmonary bypass. As you're all aware that the complications of cardiopulmonary bypass is a little more extensive than a VA ECMO. We tend to keep the apparent lower levels, and then we tend to keep the ACT on the lower levels, so it's better off with that. So this is a broad consensus that was brought by ISLT committee saying who will be eligible for a lung transplant. Any patient who has an end-stage lung disease, you think whatever condition it is, whatever diagnosis it is, a patient who has a high risk of death within 2 years if lung transplant is not offered, you do a lung transplant. Or a patient who has a higher survival rate if you offer lung transplant and may survive for 5 years or so, provided the graft function is good, then you do a lung transplant. It's as simple as that. And then you move on. And who do you pick up? So when do you refer? As indicated in all other conditions, a surgical therapy always needs a person who's been referred earlier enough. He's sick enough, but not with like every other organ destroyed, not with MODS, not in sepsis, not in acute exacerbations. So while being well enough to undergo lung transplant will bring in good outcomes. I'm just telling you a few things about certain terms. We use a common thing called as PGD, keeps going on. PGD means primary graft dysfunction. When the graft just fails, it produces a picture of ARDS in the first 72 hours. So you grade that as grade 0, 1, 2, 3 based on chest X-ray infiltrates and a PF ratio. PF ratio is between a ratio between PaO2 and FiO2. So based on that, you grade the PGD. And this is only for the first 3 days, 72 hours. And then you have these common things like, you're purposefully reducing the immunity status. So you go and get into a lot of infection. And sometimes rejection happens also. Most common is acute rejection. Hyperacute is not very common. And in lungs, usually they're present with a CLAD later on. We also have something called as lung allocation scores practiced in Western standards where they prioritize sicker patients for an earlier allocation. This is not practiced in India. And you have, again, this is taken from INSLT, consensus released on 2021. The same paper, the same publication also says there is no absolute contraindication when it comes to lung transplant. If you look at the slide, the first thing says lack of patient willingness or acceptance of transplant. Does it look like an absolute contraindication? I don't know. I mean, somebody has to give a mic to Manikandan and Dr. Mariappan, I think. So a patient who commits suicide, who doesn't want to live, will you do a transplant? A patient who doesn't want a transplant, will you do a transplant? The first ethical dilemma is there, but we have done transplants for patients who attempted suicide, especially with paraquat poisoning. I used to be very much against it, but you get carried on with this thing. The parents give consent, so that is a big ethical dilemma. So that has been broken now. Malignancy with the high risk. Obviously, if you do a transplant, you reduce the immunity, newer malignancies is going to come. We are going to be worried about newer cancers. But for a patient who has cancer, will you do a transplant? Obviously not. But there's a surgeon, I forgot his name, he's an Indian, he's in Chicago. So he's done 3 transplants who had metastatic adenocarcinomas of the lung with chest wall deposits. He's removed the deposits, he's removed the lungs, he's put in new lungs. Patients are doing well for the last 8 months. So he's publishing his paper. Probably in another 1 or 2 years, it's going to be a major thing that you're going to do lung transplant for lung cancer. So the rest of the indications, again, has all been broken. We have broken it ourselves. Acute kidney failure we have done. We are done for acute coronary syndrome, combined CABGs along with the transplant, where you put in 2 grafts at least, and we have done about 12 cases like that. So everything and anything is like broken here, and there is no absolute contraindication as such. Progressive cognitive impairment, 14th point. So suppose you have a patient who is not mentally capable or mentally suiting the physiological age, would you still do a transplant? Suppose a girl who's like 16-year-old but not 16 by mental, say like 8 years old, would you still do a transplant? Yes, we have done it. So there are broader concepts devised by the OPTN, Organ Procurement Transplant Network in US, and which we tend to follow up here also. Utility status. So if you have a bad recipient, please do not allocate the organ to the bad recipient, because bad recipient is going to get a bad outcome. Try to allocate it to a better recipient who has a better outcome. And justice, there is an equal consideration. If you have an elderly recipient, 65-year-old recipient is waiting, there's also a 20-year-old recipient waiting, you cannot choose 25 over 65, provided the 65 is a decent recipient. Respect to recipient's autonomous decision, if the recipient does not want transplant, you're not supposed to do a transplant. The timing of referral obviously is important, because the need becomes urgent as you keep going on. And ILD usually has exacerbations. When the patient has exacerbations, you have to put them, they get so much of hypercapnia, you have to put them on ECMO. ECMO-related complications are, again, going to complicate with the comorbidities and produce a poorer outcome. So, when a patient is diagnosed and referred for a transplant earlier on, we can introduce the concept of lung transplant to the family. They get adapted to the idea. And then also you have time to modify any barriers there, like obesity, diabetes status, and other problems. You can optimize them, build up the physiotherapy status, and get them a better recipient status. And obviously you do a full evaluation, do all the tests, and see if there's any risk factors, pick it up and modify it. And suppose the patient goes down while waiting, because the attrition rate is very high. 30% of the patient die while waiting for a lung transplant. So you tend to bridge them to a VV ECMO or a VA ECMO or a VVA, depending on whatever you want to do. Physiotherapy becomes very vital. You optimize the patient, build up the muscle reserve so that in a post-operative they do very well. And then once you identify a patient, everything is done, then you list the patient register and wait for donor calls. So you get these are patients being optimized on an ECMO. So VV ECMOs, and they do very well. So we stabilize them. If you are able to wean off the ECMO, it's fine. If you're not able to wean off, then keep them on ECMO and do a lung transplant. They do all very well. This is all during COVID times when you had 13 to 14 ECMOs running in the ICU. And we did about 40 transplants on COVID, and we had 9 mortalities and 31 survivals. So when the donor call comes in, it's all based on donor altruism. A family goes through such a dark stage in their life, still they choose to donate, so that has to be honored and make sure that the organs are not wasted. And we have a fantastic organization in transplant. Tamil Nadu, it leads across the country. It's a very complex and a precise corporate logistics are initiated. You need skilled medical, surgical, and paramedical people. And then once the donor call is initiated, you check in the basic things. You get the ABG done recently, which has a PF ratio exceeding 350, chest X-ray without any infiltrates, CT chest showing probably a normal lung. And then you go there personally, do a bronchoscopy, see if there's any secretions, if the mucosa is healthy. Then you open up the sternum, do a visual examination, see for structural deformities. And then you do a pulmonary vein sampling again to ascertain that the lung is functioning well across all the lobes. So this is just again a video showing that the sternotomy is done alongside with the liver. After the liver is open, you open the sternum, then do a visual examination. I mean, no need to tell you guys, all are cardiac surgeons or eminent cardiac surgeons. So you go around, encircle the venous thing like SVC and IVC, then arterial encircling, aorta, then airway encircling. That's the only thing that's different. You encircle the trachea also, so that it becomes easy to lift the heart out and then take the lungs. So there are three different types of reticle. One is combined heart and lung transplant. You remove it as an en bloc for a combined heart lung transplant. There is heart and lung shared by two different teams. So you take the heart out first and then take the lungs out. Or there is only lung transplant, so you discard the heart off and then take the lungs off. So you assess the lungs, you put the sternal retractor in a reverse way, and then expose up to the trachea, right up to the like wherever maximum possible, because you need to staple off here. So again, this is the cross clamp sequence. So what we do is at the time of the cross clamp, we discuss with the heart teams, or if we are the heart team, then we like have this procedure straightforward. We tie the SVC, then hemi-transect the IVC, then cross clamp. Or some people defer, they bend the LV by LA, clipping of the LA appendage or near the RSP. But what happens is sharing of the LA becomes a problem. So some people don't prefer RSP venting. So when the heart, apply a cross clamp and then start your solutions. So you have custodial for heart and a solution called Perfect Plus for lungs. So those are stored at colder temperatures and we preserve it around like 4 to 6 degrees Celsius. But apparently now they're doing it on a normothermic perfusion, which the results are very good. In Canada, they take the lungs and put it in a fish kind of thing where it's stored at 10 degrees Celsius. There's no more emergency transplants done at night. If you cross clamp around after 5 o'clock in the evening, they don't do transplant. They put it in the fridge and then take it out the next day. 7 o'clock, they do the surgery.
I can't see the light.
So this is the cross clamp sequence where you see the RSPV is being vented there. And that's the custodial going in, and the Perfect X goes through the cannula and the pulmonary artery. That's the LA appendage being vented there. And this is again, then you go explant the heart and then cut all the superior mediastinal structures, subclavian, brachiocephalic artery, all the other structures that you know of, and lift the lung in toto. Keep the lung ventilation on 50% of FiO2. With the tile volume, you drop it down. Suppose the tile volume is around 400, you drop it down to 250, 200, whatever you are comfortable. But at the time of explantation, inflate it to about 80% of its original volume. Hyperinflation can cause severe PGD, primary graft dysfunction. So this is again, you take it to the back table and then you prepare it. There's also a retrograde transfusion of the lung solutions there. There's Perfect that's going on. You fill in with 250 ml a solution in each pulmonary vein so that it retrogradely flushes out any clots as well as preserves the lungs also. Use the same solution, probably about 1 liter for the preserving thing in the bag. The first bag contains only lung and the preservation solution, no ice, just chilled preservation solution. Second bag probably cold saline, and the third bag contains slush of ice. There should not be no direct contact with ice, obviously you know it causes tissue injuries. And this is a green corridor. Telangana has one of the best green corridors in India. Chennai used to have some good corridors, but there is, I don't know, the standard is going down now. This is again the emotions involved in a donor scenario. You can see like people go crazy, people sanctify it, and people adore this. So there is so much of worship around this thing. So it just shows the significance of how each organ is important. This is in Gujarat. Gujarat does it like a religion. This is again on the recipient side, so you get it back, you get your recipient ready. This is how you position it. Obviously, you lift up the hands above the chest so that the axilla is wide open. You do a clamshell incision, go up to the mid-axillary region, and then that's the skin level, and then go inside posteriorly so that the chest opens like a water bucket. So this is a clamshell thoracotomy. You ligate your left internal mammary artery and the veins, go inside. We do not open the pericardium, actually. The picture says open the pericardium. We do not open until we dissect and encircle all the pulmonary veins and the pulmonary artery. Bronchus, we don't encircle. And then once this is all done and ready, then we go on circulatory support. Our standard is VA, which is 1 cannula in the aorta and the 1 cannula in the RA. So by the time the back bench, we dissect this. This is how the lung looks like with the LA cuff. So we divide it so that each side has a share of its own LA cuff, and we divide it at the level of MPA, so divide the pulmonary arteries as well, and then disconnect the bronchus at the carina. So that's basically like a pneumonectomy. Again, recipient side, you prepare them. So this is how you go around everything, and then staple it off, and get your LA cuff ready for anastomosis. So this is the suturing part, LA cuff to the recipient's LA. Again, pulmonary artery anastomosis and the bronchus. So each institution follows in a different way. We do bronchus first, go down to pulmonary or LA cuff, and then to the pulmonary artery. And this is again just a videographic representation of how that's done. Not a very clear video, probably it should be okay. That's the blue loops are the veins. Right superior pulmonary vein and right inferior probably is not very clear, it's probably down there, inferior. And the red tapes are pulmonary arteries, those are branches of pulmonary arteries. Usually you just go to the main level and then staple it off. So this is our circulatory support usual, the usual one, the VA ECMO. So one in the aortic cannula and then the other one is the RA cannula. And this is a stapling off using endovascular staples, the pulmonary artery and the pulmonary veins. This is again the anastomosis going on. Just to begin, that's a pulmonary artery. This is just an example of a diseased lung, how it might look inside. There's a combination of a ILD and a bronchiectatic lung. So this is how bad looks. You see the diaphragm being pushed up, the chest cavity is usually a bigger challenge. So size match has to be very, very perfect. And if size is not matching properly and you're desperate, the recipient is sick or something like that, then you have to do a size reduction, do a lobar transplant. So this is how it looks, a comparison. We have the right lung transplanted and look at the left lung which is completely destroyed. We're going to take it off and do it. You see there's only one cannula there. This is aortic cannula probably because the patient was on a VV ECMO. So we use the VV as IJV and femoral as a original circuit. This is again post-transplant. We usually use two ICDs on the same side, one on the surface and other one posteriorly. Sometimes, not always, it is expected for the lungs to perform immediately well. So we might need to support the lungs as well as heart. The lung doesn't show off usually. So how do you check is you do a bronchoscopy and then you do a ABG sampling. If the PF ratio is more than 300, you accept it. Around 200, even 100, okay, then you think you can use some nitrous and then get it up. All this is fine. But if still not doing well, then you go on support. And if the heart is also not doing, most of these patients have right ventricular failure. So you also support them with a central ECMO. This is a central ECMO we do, like again aorta and RA cannulation, and then tunnel it out and bring it out. So this is what we do. And this is how we bring it out, tunnel it out, close the chest, extubate the patient also, do whatever you want to do, keep the ECMO, then take them again once the patient is fit, and then decannulate. This is again for a patient who had right ventricular dysfunction. So proper assessment is needed before taking. The recipients has to all be followed on protocols. Every 2-3 weeks you have to keep following up. This was a patient, we missed them on a follow-up for almost a month and then we realized the heart has really gone bad and the right ventricle was not coming out. So we had to do a right ventricular support. This is probably the first time in India we did a protect cannulation, which means the cannula just goes in and bends into the RV and then goes into the PA. So you're venting only, you're like an ECMO support only for the right ventricle. Unfortunately, the patient didn't make it too well. He had sepsis and then he succumbed to it. So this is again the cannula. You can see it's like your pointer or something like that. Okay. So that's the cannula going up to the pulmonary artery. So again, this is one of the modern advances. I'm not sure how to call this. There's a lot of gray areas again, whether Indian patients can afford this. This is a technique called as EVLP, ex vivo lung perfusion. The problem is you go to 10 heart retrievals, you get mostly like 70 to 80% of retrieval rate is there. But for lungs, the retrieval rate is about 15%. You go to 10 retrievals, you might or might not pick up 1 or 2. So the retrieval rate is very poor because the lungs get affected by infection. It's one organ which communicates with the external environment, so it gets badly infected. So AVLP is a technology where you try to perfuse the lungs, stabilize it, control the infection, or make it better. So this was the first time in India when we used it. And I was very fortunate and blessed to be a part of it. But this is how you take it, harvest it, and then you perfuse it outside, maintain it. Every 1 hour, you keep checking the parameters, do an ABG, everything, and then see if the lung improves. This support has to go on for minimum of 6 hours, but unfortunately we had to call it off after 3 hours because the lung was going down. It was a borderline lung, but the parameters were worsening. So we had to call it off at 3 hours and then we had to transplant, and luckily the patient did so well. But the problem is technology is very expensive. It takes about 25 lakhs to every time to initiate this, and after 25 lakhs of investment, if the lungs go bad and if we decline, who will take the cost? So it's quite an expensive technology, but it's commonly being used in Canada, Toronto. So their conversion of a lung is about 70 to 80% on a EVLP, and the EVLP is covered by insurance, so not a problem at all. So sometimes, in spite of all positive things, this is a donor. 19-year-old. She had this perfect pink lungs, 1-day ventilation, ABG was flying in the air, PF ratio 500, bronchoscopy was clear as good. And this was possibly the best lung. I took it from Mangalore, Father Muller's College, brought it back, so enthusiastic, size was a perfect fit. But we almost lost the recipient because of severe infection. She grew Pseudomonas, Klebsiella, and mucor, like all three, like 2 bacteria and 1 fungus, which is very detrimental. So in spite of all good things, a good donor organ and a smooth surgery, the post-op can be extremely challenging. And complications will be usually galore and a very unforgiving first-year follow-up, and there's a huge financial strain. And still, why do we keep doing this? And this is my favorite quote, and this is a very favorite quote and a very close to heart quote for all the transplant surgeons. The core of this is, anybody who's involved in transplant, they do not remain the same. They get destroyed, they get sublimated, but they don't remain the same. The experience is very traumatic, it's gratifying, it's satisfying, it's all a mixture of combination of emotions. But still, why do we do this? So there are so much of unpredictable schedules, no social life, morbidity and mortality will break sanity. There are so much of gray areas of ethics. We don't know what we are doing. We don't know whether we are doing the right thing or the wrong thing, but we're just trusting the science and progressing in. And there is so much of shallow professional etiquette also. There are 2,500 cardiac surgeons in India, possibly a little more, but there are only 20 odd in transplant scenario. I don't know what's the reason why the people are a little low. I keep asking this question. I have a lot of discussions with my colleagues, Nanda and Dr. Manikandan, that we should probably push it a little more, trust the science a little bit more, and then, the one common thing that we find in transplant teams is they are teams. And the one common thing you find amongst cardiac surgeons is we do not want to exist as teams. Which is a very sad thing. And the amount of resources, the amount of infrastructure the Tamil Nadu government has is phenomenal. The willingness of a donor altruism is too much in Tamil Nadu. Like you will see like 60-year-old, 80-year-old women walking up to the cardiothoracic floor and say like, where do we donate? Kind of thing. Such things are like in the roots. It's cultural now. So I think we should just manipulate all these things and get the best of the science and probably move on forward and produce more numbers. And the government scenario is already doing well. Dr. Marivan has done a lot of transplants. Omandara is doing a lot of transplants. And it's very heartening to see a lot of good results coming out. But we want more, and we want the highest standards in the government setup. So is the science rudimentary? Definitely no, I think so. Are we rudimentary? Possibly yes. So what keeps us going? There are moments in our lives too, like which is very gratifying. You see this girl, 22 or 3, I'm not very sure, very young girl. She consumed paraquat poisoning by an accident is what has been documented. Treated in a local hospital. She came to the ER. Luckily, I was there available in the ER when this was going on. She came with a PCO of 140, hypoxic about 60 to 80 on a ABG, and then I had to rush in, bring her to the ICU. She was arresting. I took a trust saying that the hypoxia was a cause for the arrest, did a VV ECMO, and then we salvaged her. And 21 days later on, we gave her lungs. That's the anesthetist phase. He is the key to our transplant program. This is again subsequently a good result.
Are you feeling good?
When you extubate them on the post day 1 and they take the first breath of life, they feel so well, because they've been gasping on oxygen for the last 1 or 2 years. These are furthermore results. This is the same lady after 1.5 years of follow-up. She's doing too well. She's got 2 kids and she's quite happy. This is one of the very textbook case, very close to my heart. This patient came to me in Rela. We waited for 9 months for this patient. This patient had a lot of trust on us. So that is what the whole process takes. If you want to go in a very ethical direction and just follow complete science and not be like, taken over by emotions. So this patient came in, was on 2 liters of oxygen. Her PCO was around 50 to 60, slowly started deteriorating. Her PCO was building up to 80 over the 9 months' time. She was getting sicker and sicker. But the family was very supportive. Our daughter is a doctor in Gujarat. The government of Gujarat supported her with 15 lakhs more. There was fund collection. So we got in around 35 to 40 lakhs. And about 9 months later, we got a good donor from Rajiv Gandhi Government General Hospital, 19-year-old who fell off a scooty, fantastic lungs. And look at the amount of preparation she's done for ourselves, a very good physiotherapy, morally motivated. Day 1, we extubated less than 24 hours, just went off like an ASD. And then, not even in CABG patients, I would seen like them doing incentive spirometry like this. It was amazing. She got the 3 balls up in day 5 or something like that. She's doing too well for us now. So moments like this are very, very, very gratifying. And this is what pushes us more towards transplant. So this is my team. And we are 2 surgeons. Actually, a transplant team requires about 4 surgeons. Somehow we are managing it with 2 surgeons. So again, the core thing is coexistence is not there. Trust is not there. people are very insecure. I think we need to build the team rapport, and then once you have a good team, then these things becomes very, very easy. So this is my core team in Chennai. This is my team across 3 states. So you see this group, there are 2 surgeons, 1 anesthetist and 5 transplant pulmonologists. The transplant pulmonologists play a very critical role. You have to trust them. They lead the team. They give in the recipients. They take care of the recipients. So this is again our team in Bangalore. And thank you for this opportunity, and great meets Dr. Meenakshi Sundaram and your team. Like, it's a fantastic setup. And it's an honor to be here in front of such a large crowd. Thank you again.
Thank you so much, sir. It's an honor to welcome you.
We'll take the questions out of the inauguration. Yeah. Mani, you have anything to say?
Sir, let's have the question session later.
Sorry?
Inauguration முடிச்சிட்டு வச்சுக்கலாம். சார் இன்னொரு சேர் கொடுங்களா? சார் என்ன பண்ணிடுறேன் இல்லை இது ஓகே சார் என்ன பண்ணிடுறேன் சார் என்ன பண்ணிடுறேன் நான் Thanks for the first session, sir. And may I now invite Professor R. Mani, our beloved director, Tamil Nadu Government Multi-Specialty Hospital, on the dais, please. And I would like to welcome Professor G. Kumar, sir, Medical Superintendent and HOD Anesthesiology, on the dais, please. And Professor B. Mariappan, sir, please, on the dais, sir. Director, Cardiothoracic Surgery Department, Rajiv Gandhi Hospital. I would like to welcome our HOD, Meenakshi Sundaram sir, to the dais. So, thank you, esteemed guests. I would like to invite the dignitaries to light the lamp. Sir, lamp. Sir. I would like everybody to stand up.
நீராறும் கடலுடுத்த நிலமடந்தை கெழிலொழுகும் சீராறும் வதனமென திகழ்வரத கண்டமிதில் எக்கணமும் அதில் சிறந்த திராவிடனல் திருநாடும் தக்க சிறு இறை முதலும் தரித்தனரும் திலகமுமே அத்திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிழமை திறம்பியந்து செயல் மறந்து வாழ்த்துதுமே வாழ்த்துதுமே வாழ்த்துதுமே.
May I now welcome the chief guest to honor us by lighting the Kuthavalakku.
ஃபோன் அங்கே லேம்ப் லைட் அவங்க வச்சுருக்காங்க அங்கே இருக்கு அங்கே நெக்ஸ்ட் லேம்ப் லைட்
Lamp lighting. Please. May I now invite Dr. Meenakshi sir. Shall we talk? Okay. Welcome.
Good morning, everyone. On behalf of the Department of Cardiothoracic Surgery, Multi-Super Specialty Hospital, I would like to invite our beloved Dean and Director Sir, Dr. Professor Mani Sir, and our beloved Medical Superintendent, and our colleague and team partner. He is our Chief Cardiac Anesthetist also, Professor Dr. Kumar Sir, and Professor Dr. Mariyappan Sir, who is my teacher also and mentor also, Professor and Head of the Department of Madurai Medical College, Madras Medical College Cardiothoracic Surgery Department. I would also like to invite all the faculties from other medical colleges, Stanley Medical College, Multi-Super Specialty Hospital, Guindy, and Madurai Medical College Department faculties, and Salem Medical College Department faculties, and few other private medical colleges, my colleagues from Pondicherry. This is a great occasion, and the topics were also carefully selected so that we have at least 10 to 20 CMEs throughout the year. So if we thank you.
Thank you, sir. I would like to on. Check. Okay. Sir, please honor our chief guest. HOD Meenakshi sir will honor our chief guest Mani sir. Thank you, sir. Our HOD will now honor our Chief Anesthesiologist and Medical Superintendent, Dr. Kumar sir. Thank you, sir. Now I would like to invite Mariappan sir, our chief guest, director from Rajiv Gandhi Hospital. Meenakshi sir will honor him with a shawl. Thank you, sir. Thank you. Sir, I would like to invite Dean sir for Vaaduthurai. Sir, Vaaduthurai, sir. Sir, Vaaduthurai, sir. Vaaduthurai. Yes, sir. Sir.
Respected Deputy Superintendent of our hospital, Professor G.K. Kumar, Professor HOD for Cardiothoracic Surgery of our hospital, Dr. Meenakshi Sundaram, HOD of Cardiothoracic Surgery, Rajiv Gandhi Hospital, Madras Medical College, Professor Mariappan, respected Prem Anand, respected Mariappan, respected Manigandan, respected Abhinaya Vallaban, respected Shivan Raj, respected Muthu Vijayan, respected Saravana Krishna Raja, respected Nanda Kumar, respected Vignesh, respected Shibi Duraiswamy, and various professors and assistant professors from other medical colleges and other, maybe from the Pondicherry also, and our colleagues. Indeed, a great pleasure in attending this CME program, a glimpse of advances in cardiothoracic surgery, a very well topic in this era, need of an hour, because lot of advances are taking place in medical field, especially in surgical field. In our hospital, we are doing lot of surgeries. At least average per month, we are doing 25 to 30 surgeries. Every day, except Sunday, we are all doing surgeries. And we are doing robotic surgeries also, at least 2 to 3 cases per month. and we are doing a micro-invasive cardiothoracic surgeries. So far we have done 6 heart transplant in this our hospital. So average we are seeing around 2000 cases per month, at least 80 to 90 cases per month. It shows that how the department functions well, how the leader is doing well. So in this juncture, I would like to congratulate all the staffs and assistant professors and HOD of cardiothoracic surgery. Give them a big applause to encourage them for the future, this thing. The surgical field not only to save the patient, but you have to learn the recent advances. That is very, very important. Previously we used to open the sternum or any part of the chest to enter into the heart or the lung. Nowadays by micro incision we are entering, and recently the robotic surgeries are we are doing. So this type of facilities are more needed, and it is available in our hospital. So you can refer the patients to come over here, or if you want to get trained in robotic surgeries also, you can come and get trained here. I think the topics given here is very, very important and need for the youngsters, and a lot of great scholars have come to share their knowledges. I request all the assistant professors or beginners to listen carefully and learn from them the skilled activities. I wish this CME program a grand success. Thank you very much.
Thank you, sir. Very honored to have you here. And Sir, I would like to invite Kumar sir on stage to say a few words, please.
Very good morning to you all, and respected and our beloved director and the HOD of the RGGH Cardiothoracic Surgery, Dr. Manipan sir, and other professors and dignitaries. We are happy to see you all in this auditorium, and that too in our hospital for academic purpose, especially from the Cardiothoracic Surgery Department. The department is always very active here, and they will always function as a unit. I never seen nobody left the campus till the case is shifted to the post-operative ward. That much of the dedication and involvement that the team is always showing towards the patients and other activities. And apart from that regular clinical work, once again, it's happy to see them all for the academic purpose. And thanks a lot, sir, for bringing this kind of the academics in our hospital. We expect more and more from you. In two aspects, we are beneficial and we are a little bit free on Saturdays also. Thank you very much, and we welcome you for the hospital also. As a deputy superintendent of this hospital, we welcome you all also. Have a wonderful academic feast. Thank you very much, sir.
Thank you very much, sir. So now I would like to invite Maripan sir. Yes, sir. To say a few words, sir.
Good morning, one and all. Actually, within the short period, our Meenakshi Sundaram has organized this program. Individually, he met all the people and he took full effort to, because we are less in numbers, not much number, postgraduate students also not with them. Still, he almost organized some good crowd. So, I congratulate for him for the successful CME program. With this, I finish up. Thank you.
Thank you so much, sir. At this outset, I would thank Professor Mani sir for having come and grace this occasion. I would like to thank Kumar sir for his, in his busy schedule, he has allowed his assistant to come and then grace this occasion, and his presence is awesome. And I would like to thank Professor B. Maripan sir. In spite of all his busy schedule, he has asked his students and assistant professors to have come and attend this program. Thank you so much, sir. Thank you. We now conclude the inaugural session. I would like everybody to stand up for the national anthem.
गणमन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उज्जल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Please be seated. Sir, Maripan sir, please be on stage, sir. Question and answer, sir. Morning, sir.
Actually, I congratulate Prem
Thank you, sir.
because he was with me as assistant professor in GH. He helped me a lot, especially when I was in budding stage of bleeding heart surgery. He worked so hard to support me. In spite of so many hindrances, I don't know how much hindrance he was faced, I don't know, but still he helped me a lot. I am so happy that he grown like this, because apart from, in fact, heart transplantation successfully is better, very good than lung, but he is handling lung transplant. He is authority almost, he displays so many videos also. I am so happy that he is grown like this. My question is, one of few questions for academic point of view.
Yeah.
See, what I observed is anastomosis and hemostasis. That is very, very important. Whatever skill, whatever anastomosis being done, sometimes we are having bleeding issues. Especially in case of heart transplant, LA, in case of single lung pulmonary artery, anastomosis very, very difficult, and we can't see, once again we can't see. Do you have any idea about the sealant which used to as pentals, like as a sealant we are using or anybody is using? Is there any role there?
So that's a brilliant question. Before I start off, like you said, shared, I had a very wonderful moment with Dr. Maripan for 2.5 years, as assistant professor, and it was a fantastic learning experience, both in the science part and as well as the human part. He's a great human being, and he pulls out his money and from his own pocket and does a lot of charitable work also. And also as a surgeon, he had that willingness to push frontiers and borders and boundaries in spite of all the criticism that was going on all around him. And he constantly believed in himself, and there were a lot of good things I took from his experience. And whenever I go outside, and then there was a credit given to me in case of any vascular anastomosis, I think I owe it a lot to Dr. Mariappan. And also answering to your question, sir, to the general cardiac surgery, the principles of tying down the knot. So we use hook. Hook has to be used for any anastomosis. except probably coronaries, because it becomes too difficult to pull out the knots. So what happens is, you take a circle, you start the anastomosis like a circle. So you start from the posterior part, like say like 3 to 9 or 9 to 3, whichever is comfortable. So go from one direction to other direction. And then before you go on to the anterior part, use a hook to loop up all the threads and make it tight. And in transplant publications, they recommend saying if you do not use a hook to tighten your threads, do not do a transplant. It is that important, and I've realized the importance over a period of 7 or 8 years. Now all my anastomosis, I do that. Even if I know it for sure that the threads are tight, still the final thing comes down, you use the thread, lift it up, tighten it posteriorly, and then at 3 o'clock, and then you complete the anterior. And what we do is we use stay threads at 3 o'clock, 9 o'clock, and 12 o'clock or posteriorly also 6 o'clock. We use them, we call this tension or like hook sutures or whatever it is. So you tie them up. You have half-length sutures at these intervals and then tie them up. You won't need any sealant at all. So in my 2018 onwards, I started my transplant. Now it's 7 years, I've hardly used a sealant. So that is very important. And then if there is a need, we use sealants for artificial devices. When you implant left ventricular assist devices, then we panic a little. In spite of all good hemostasis, then we would not want to take a chance. We use sealants then. Sealants can be anything. So right now we use BioGlue. That's the only thing we use. And we see there are more complications using sealants than, just the natural ones. So we use Fibrilla. That's the maximum we use. So anastomosis, always with the hook. And then tension point sutures. You go around 1 or 2 layers extra, that doesn't matter. And finally, fibrillar, maybe. Like that's the only thing we use. So.
Okay, thank you. Yes. Another question. Actually, when I was auditing in lung transplant, so many people's written PA and anti-HLA, like panel reactive antibody. They are doing or just the way they are writing, because PRA plays main role in lung transplant. Are really they are doing or not? Just openly tell.
Yes, sir.
I feel most of the people are not doing.
No. All transplant centers who are doing lung, they're doing it. We do not do without HLA incompatibility, because this is a major threat. The patients will go down immediately. The chance of rejection is very high, and then it reflects very badly on the transplant team. And these patients are all like spending about 40 lakhs is the lowest value. So when I was in Hyderabad, Kim's Hospital, the lowest bill for a lung transplant was 1.65 crores. When a patient is that educated, when the patient is investing so much, I would recommend the team to put in all the efforts possible, and basic HLA compatibility testing is a mandatory thing, and we do not reach on that. So we follow all signs, because the level of documentation, all the scientific protocols has to be implemented, because we are in big trouble if the patient goes down. If there's a bad result, some of them are all in elite positions, like Supreme Court judges and all this stuff. They would sue us to the paper. Yeah, it's very difficult, so we do that.
Any questions from the audience?
Congratulations, Dr. Prem, for the wonderful presentation and
thank you, sir.
Nice videos. We enjoy the videos a lot.
Yes.
And I'm personally happy, like you have reached so much of heights, and being an authority for Tamil Nadu to do a lung transplant. I'm really happy, and I wish you all the best from the bottom of the heart. And 2 questions basically. Like one is the absolute contraindication. You said like you have broken the myth, and the absolute contraindication is not the absolute contraindication, and we are doing transplants for the terminal stage malignant patients, as well as a psychologically down patient or a patient who's going to commit suicide and all. But in the other end, the beginning, it was a point like the donors, even though the increase in number of donors, but the waiting list is huge. Are we justified in putting a lung transplant for the absolute contraindication? That is my first question. And second question is, what is your take on lobar lung transplant?
Yeah, so that's a very, very brilliant question. And again, before I go through, like Dr. Shivanraj is my teacher also. I learned my first MA from him. So yeah, it's a great thing. So that's a very brilliant question, I would say. There's a lot of ethical dilemma there, because the donors are there, but the lung picking up ratio is very low. Why would you put a good lung to a poor recipient? Yeah, we have not done that. I'm just telling you, this was done by Ankit Bharat, an Indian surgeon from Gujarat. He's there in Chicago, he's doing it. when the Western
And
world,
what is your take on that? Is it good or
my
you don't
personal
accept
thing.
it?
So my personal thing is, lady who has committed suicide, attempted suicide, paraquat poisoning. I would say no. We had a discussion on Zoom call when I was in Hyderabad, and Dr. Mohammad Rela was calling us. We had a tie-up with all the other hospitals like D.Y. Patil, Rela, Aster, Bangalore, and all this thing. So there was a Zoom call, and they said we had to do a transplant for this patient who was very young, who was a doctor, who was committed suicide, attempted suicide, paraquat poisoning, very classical. Everywhere in the world they do this transplants as a therapy. So he was, I didn't know Mohammad Rela was sitting on the Zoom call other side, and the presenter was there. I said, we will not do it. But that's my personal take. A person who's not interested in living ahead needs psychiatric counseling for at least a year and recovery from that for any other things. This is a standard recommendation by the medical law in India right now. So I would personally not reach that. But there are gray areas there, when they say like in a moment of hastiness, they have taken a decision, why don't we salvage them? Because lung is the only organ that's going bad, kidneys are salvaged, liver is good. So there's a immediate medical urge to save the patient. So this is a conflict of thoughts. But again, like you said, it's a potential resource for some other person who's dying. I think you should use it for that person who's already there on the list. We do not have a lung allocation scores asset. That is one thing. So if we have lung allocation score, these things will be bypassed. They will not get a lung. The sicker recipient will get a lung. So these are things which has to be implemented in India. But unfortunately, all the transplant surgeons or all the transplant hospitals has come together towards a consensus, which is extremely difficult in India. And you know why, right? So, and then the second question, lobar transplant. Yes, sir. There's been a couple of experiences. Again, we in Gleneagles did a first bilateral low lobar transplant. Patient is doing well right now. Patient is also sick, I would say, by the lobar transplant, it's been the first successful lung transplant. And also, there are other things that is affecting the patient. The patient is a very poorly prepared patient. Patient is not doing any exercises. So she's still there in the ICU recovering. She probably should go out. And 3 lobar transplants we had attempted earlier in Hyderabad have all failed. Lobar transplant has always been scientifically it looks easy. Take a lobe and put it there. It suits the chest wall, fantastic, all that's fine. But somehow lobar transplants has not been doing well across the world. We're not very sure what's the reason, exact reason. They succumb to sepsis, I don't know why.
So in any case of lobar transplant, have you shared the lobes to 2 or 3 different patients?
No, we have not done live donor. We have done a lobar transplant because the patient, we had a female patient with ILD. ILD, the chest cavity is always shrunken. She was 150 centimeters, 145 centimeters, and we got a male donor, which is like 174. Male to female, already the size is a mismatch. And you go and I got a huge lung. So we mentally prepared ourselves saying there's no other way she's going to get a lung. So we knocked off the upper lobes, middle lobes, and then we put in bilateral lower lobes, and it was fantastic.
Sir, I'm CTS assistant, sir. MMC, Dr.
Yes.
Sendar.
Yeah.
Sir, I have one question for you. And I am PG, I work in Sivaram sir unit, sir. We planned for a bi-lung transplant. We called Sundar sir. He told that we cannot do lung transplant in your hospital. You work in our hospital and you went out. What we lack in our hospital to do lung transplant?
You call me next time. I'll come and help you. You need to talk to the right people, I'm telling you. So the thing is,
He told that post-op we cannot.
the amount of hands-on we have in Madras Medical College and the Omandara, this is phenomenal. It is not anywhere seen across the world. The amount of hands-on we get on open heart surgeries is huge. So when I went to transplant unit, when they were all thinking that the same look down is there, GH trained, they might not do well and all this stuff. But when they saw the quality of work coming in, they realized our hands-on is unbeatable. But what we do with that hands-on apart from our training, and after that is the question now, how well we sharpen ourselves, how well we refine ourselves. Dr. Marivan has been doing heart transplants here. Omandara has been doing heart
lung
transplants.
we cannot do it. He told lung we post-op we cannot.
That is what I'm saying. Once you do a lung transplant, surgically, you will realize it is easier than a beating heart CABG. There is no stress on your brain. The lungs are not going to bubble up, it's not going to beat, it's not going to show that it is dead. Lung complications are going to come in later by the time you've done your surgery and not.
Post-op complication, you didn't face any difference between
Sorry?
lung and post-op complication between heart and lung.
Forget post-op complication. The first part is critically surgery. Surgery, it's all macrovascular anastomosis. One of the transplant surgeons I know doesn't wear a loop also. Because it's macrovascular, it's not coronary anastomosis. So it's very simple. So next time, what you do is, you identify a patient. If you have your setup in your Rajiv Gandhi hospital, there will be hundreds of recipients, I understand. You go to the pulmonology department, you will pick up a lot of cases. You pick up anything. microsilicosis or like whatever, like ILD or bronchiectasis, so many destroyed lungs are there. Like, choose a patient. What we'll do is we'll collaborate. I have my team, like, we can discuss the discussions, pre-op evaluation, post-op evaluation, management, all those things we can sort out. Once the patient is ready, you list the patient here. As a team, we'll come out and help you out with the surgical things. The first transplant you can do, I keep saying this to Dr. Manikandan, everybody is equipped to do a transplant. And after that, the management also is quite easy. As CT surgeons, you'll be doing more work than the peripheral hospitals. You are taking care of ICUs, right? We don't do. It's been 8 years since I spoken to a patient after surgery. I don't even go to the ICU. There are capable anesthetists, 5 trained transplant anesthetists who will take care of the scenario. So my job is actually easier on the corporate side. Your job is more intense. You guys are more knowledgeable. I don't even know the spelling of fever now. It's that much how my knowledge is deteriorated. I have focused myself only to the surgical skills. This has been my mentor's thoughts also. As a surgeon, focus only on your skills. You are a surgeon, please be focused on that. You cannot say, I want to do housekeeping work, I want to wash the clothes, do a transplant also. You have to dedicate yourself to make sure, like Dr. Marivan said, no bleed after your anastomosis. Your hemostasis is perfect. Your anastomosis is all clean. Then you come out. Surgery is just 20% of transplant. The 80% is post-operative care. We'll get you there. You get your patient there, talk to the right people and connect. Okay, people who are very insecure about themselves will not help others. Yeah. So you have a patient, you don't lack anything. That's what I'm trying to say. GH does not lack anything.
So we do more on heart transplant, sir, but we avoid more
heart
on
transplant is difficult. Your LA bleeds, it's gone, right? But lung, you bleed like the last patient we did, we re-explode 5 times. So it's not because like in private sector we are doing external, we are also learning. We go through hell. They bleed, they have complications, the anastomotic dehiscences, you keep going in again. There's a constant learning process for us also. There's nothing that you lack surgically. There's nothing that you lack infrastructure-wise. All you need to do is put your heads together. You need to talk to a pulmonologist. Pulmonologists might not be aware of certain things. You need to talk to your anesthetist. You need to have a team. You need to have a surgical assistants. You need to work as a team. That is what I've been telling. Transplant requires a lot of alphas coming together, which is what is lacking. And some I'm telling you, the leaders of a lot of cardiac surgery is MMC. Why should we lack in transplant? There are a lot of things Dr. Shivantraj streamlined. The lot of questions he asked. Me and Manikandan went to the transplant office, which was originally in Madras Medical College, and said, boss, why are we not getting transplant? They're saying, boss, you did not even renew a license.
I was in MMC for past 10 years, sir. We have done a lot of heart transplant, but lung transplant, I don't think.
I think it's high time that Madras Medical College, sir, I think you should do a transplant, because he's been in the leader, he's been pushing borders, frontiers, and then he's got heart transplants done. And now he's realized how easy an heart transplant is. I came to heart transplant. So I was asking, do you do a workup on a panel, PRA? We do that, all those things. So first transplant patient, we went and we had 4 papers, case sheet. One was written from cardiology referred to cardiothoracic for heart transplant. That is all it is done. That was what it done. But still the patient went out because of the brilliant work. There's so much needed. You need a right heart cath study, you need so much cardiac MRI, all these things to prove, but it was not there. We are very raw, but we are fantastic. All we need to do is just believe in yourselves and keep going. Lung transplant, I'm seriously urging you all, get your recipients. We'll come as, we'll provide you all the skill sets.
Post-op management matters no, sir.
Nothing.
And
post-op management, nothing.
Excuse me for interrupting. And we have still more sessions, I think.
Thank you.
Actually, the topic was chosen based on this only. We have to start lung transplant, and we have support team.
Thank you, sir. Thanks.
And thank you for the
sorry for interruption.
No, not else. Thank you for the opportunity, and probably
we'll move on to the
next
session.
Yeah, thank you.
Congrats, Prem.
Thank you, sir. Thank you, Prem, sir. Thank you, Maripan, sir, and Manikandan, sir. We would like to take a tea break now for 15 minutes. Please assemble here by 12. நிறுத்தலாம். May I draw your kind attention, please? Second session. Please kindly everyone be seated. We would like to start our second session. Inga, speaker. என்னோட பிட் எங்க இருக்குன்னு தெரியுமா? ஓகே. Muthu sir. Okay, Shivan sir. Shivan sir. Yes sir. Attention please. We would like to start our second session. This session is the topic for this section is experience and outcomes in robotic cardiac surgery in government hospital setup by Dr. P. Abhinay Vallavan. Chairpersons, I would like to invite Dr. Shivan Raj sir and Dr. Muthu Jain sir on the stage, please.
Good morning, everyone. I thank my HOD to give me a chance to speak about the experience and outcomes in robotic cardiac surgery, which we do in our hospital. And this will be a short talk, it will take some 15 minutes. I will just share our experience, what are the difficulties we faced during the startup of the robotic cardiac surgery in our setup, and how we overcome those difficulties, and we'll play short videos of cardiac robotic surgeries we do here, like Lima harvest and AST and mitral valve replacement. Recently we had a robotic thymectomy also, but I didn't add in this talk. So why minimal invasive and robotic cardiac surgery in our setup? Our aim was to provide world-class health to the common people comparable to the private hospital. And second thing will be to improvise ourselves and our skills. And in order, by improving ourselves, we can sustain and sustain in this field, which is over competitive. The advantages of mix and robotic surgery are, it is though the initial cost of setting up like in the robotic instruments and robo and minimally invasive are over expensive, the potential cost saving will be in the long term. We can see the long term benefits as it will increases the bed turnover, so that we can reduce the duration of stay in the hospital, and the resources we need for the remaining 5 days will be cut short. So that will also reduce the burden on resources. And the second most thing will be there, we can attract and retain the skilled surgeons in the government setup. Though most of the surgeons who are trained in the government setup will finally leave the government service and join the private hospitals. By introducing the minimal invasive and the advanced features, we can retain the skills within the government setup. So nowadays there is also increasing patient expectations. Though there are many websites or videos from they are seeing the latest advance in cardiac surgery. They come and ask, are you doing minimal invasive surgery without stenotomy? So all these things made us to start minimal invasive and robotic surgery in the government setup. So coming to the advantage of robotic surgery per se, the main advantage of robo is we can have a three-dimensional view, and we have a high definition stereoscopic vision. And apart from that, second most thing is the surgeon can sit comfortably and operate. And third thing will be the enhanced dexterity, and we can reach the remote difficult access areas, which are the main advantages of robo we see. And third thing will be the tremor reduction. Some surgeons may have tremors during surgery. This thing can be eliminated by the use of robo. The last thing will be the telesurgery, which is not famous here. Not routinely done here, it's on the preliminary stage. The first government sector to install the robo is at AIMS, New Delhi in 2006. Though it was set up in 2006, the takeover by the surgeons and the use of robo was very minimal till 2015 or 2020. Due to the lack of because of the challenges they faced, like high initial cost in investment, and the ongoing maintenance causes expenses also very high, and there is a deep and there is adoption and a steep learning curve for the surgeons to be comfortable with using the robo. So coming to our setup in Mohammadrar Hospital, we installed our robotic system in March 2022, and we installed DaVinci Xi Robo, which is the latest version of DaVinci. And we got a dual console system where two surgeons can operate simultaneously, and we have a stimulator in one of the consoles where we can train ourselves also. This is the setup of a DaVinci Xi Robo. It consists of a it consists of a surgeon console, patient card, and the vision card. In the surgeon console, we have a three-definition view of the operative field, and there is a working arm here, and all the controls will be on the foot level. And the patient card consists of 4 arms in the DaVinci Xi system, and we dock the instruments in the robotic arms and we'll operate. The third thing will be the vision card. It will consist of a TV connected to the vision card, where all the operating or the in-theater staffs can visualize what we are doing inside the robo. And it also consists of the energy source and the light source as well. All the three were connected by the internet. So everything will be interconnected and we can operate easily. So initially, one surgeon and one bedside surgeon was formally trained by the DaVinci people. And we did our first robotic case on 16 July 2022, which is robotic Lima harvest followed by mid-cap CABG. So this was the first procedure we had done, and this was the first, for the first 50 cases we have done only robotic Lima harvest followed by mid-cap CABGs. And we first standardized this procedure, Lima harvest by robo and mid-cap CABD, Lima to LAD. So over the past 2 years, we have done 50 cases of robotic cardiac surgery, and we have progressed and trained, and we have developed our team. We successfully expanded our robotic program, and we have done our mitral valve replacement and robotic ASDs, and we are currently venturing into the robotic thymectomy also. So far, we have completed 75 robotic cardiac cases in the span of 3 years. So these are the difficulties we faced during our starting up of the program. We don't have a planned or a robotic cardiac team development, and we have port placement difficulties in the initial cases, and we lack a dedicated mix instrument. For the past 2 years, we don't have any mix instrument. We used open instrument. We modified and we used those as a mix instrument. We also faced difficulty in managing single lung ventilation. Time is the second most factor which prevented us from routinely doing the robotic cardiac surgery. As initial cases, we took around 3 hours to harvest Lima. But now we are harvesting our Lima by around 45 to 50 minutes. Though it's not up to the mark to the national level, so we are still improving on that. And the final thing will be the presence of lung adhesions. So how we improved by facing those challenges? We have a case-by-case decision making. The robotic team consists of surgeon, anesthetist, perfusionist, and staff. Everyone will see the patient. Everyone will tell their ideas. Each one will take all their opinions and will finalize the case. We don't have any strict protocols that this patient will go robotic and this patient does not go. Every patient will deal with separately, and we'll tailor fashion each cases. And as I have already told, we have used our conventional robotic cardiac retractors and octobus for minimal invasive surgeries. So another major thing we have improved is we have changed from double-lumen endotracheal tube to the bronchial blockers, which made the lung isolation very much easier. as we have faced difficulties in placing double lung ET tube. It's sometimes we have injured the trachea. We have faced that situations also. But switching over to bronchial blocker, the work of the anesthetist also decreased very much, and has given a very good lung isolation. And the fourth thing will be the cost minimization. How we cut down the cost during the robotic surgery is by minimizing the number of instruments we use, because each instrument costs around 1.5 to 2 lakhs. So we used instruments that are absolutely necessary for our surgery. For example, if you want to cut, we can cut both with the spatula and scissors. So we will select any one. If you use spatula, you continue cutting with the spatula. Don't change with the scissor. It will cost, even though if you cut one time, it will cost around 1.5 lakhs for that. And use of clip applicator also we have reduced. For the first 2 or 3 cases, we used around 20 to 30. The first case we have used about 40 clips. The clip applicator cost around 2.5 lakhs. Each we can apply only for 100 times. Again, we have to throw it off. So each cost of a clip will go around 2,500 rupees. So what we have done is, we efficiently use the bipolar cautery, which seals the branches of the lemma very efficiently. So we decrease the use of clip applicator to around less than 10 nowadays. So tackling adhesions, initially we opened up when there are lung adhesions during lemma harvest or ASDs, but as we progress, we dissected and released the lung adhesions robotically, and we proceeded with our planned procedure. So after we have gained our confidence, we progressed with procuring our minimal invasive cardiac surgery instrument, not a whole instrument. What are most essential we got from our internal funding, which makes our work somewhat easier. So these are the selection criteria during our initial days. We'll strictly follow with these ones, like thin or moderately built, good target vessels, adequate lung function and without lung adhesions, and preserved LV function dimensions. These gave us the better results. Now as we have trained, we have some loose ends, so we do it in obese patient also sometimes. So I will show you 3 most common surgeries we do in our setup. First one will be the robotic lemma harvest. Here the positioning will be the slight right lateral position. We place a pressure bag over the left shoulder, and we very much look into the chest X-ray, how the port placements will be. Every patient will get a drawing and see how far the apex of the heart goes like. If it's like in the 5th intercostal space, we go 1 space above and place the camera port over here. Or nowadays, as we have trained up, our routine camera port placement will be just lateral to the nipple on the left side for lemma harvest. So 2 spaces above, we place our second space for the right instrument, and 2 spaces below, we place the second port on the left port. We use this camera port and extend it as mid-cap incision later for lemma to LAD grafting. So this will be our lemma harvest setup. We only use the 3 arms. We don't use the first arm. The second arm or the left arm will be, we have a bipolar cautery. Center arm will be like camera, and the right arm will be like a spatula. I will show you the lemma harvest video. After camera placement, this is the right port. We place on the second intercostal space. We like to go where vagus nerve and lemma join. This will be the left port. After our port insertion, we bring spatula in and place it in ideal position. And then from the left side, we bring the bipolar cautery. Once this thing is made, we can go to the console area and start operating and releasing the lemma. This is 2 times fast forwarded. We dissect the fascias first, and once we dissected on both medial and the lateral side, we dissect our branches, and we'll clip the. We'll clip it. Initially, we placed clip on both sides of the branches, And for cost cutting reasons, we started using the spatula and cauterized the other end. Sorry. This is the same thing, we are clipping and we'll cauterize. Once you are cauterized, we will separate from the remaining adhesions. And this will be after complete release of lima from its bed. We like to remove all the hinges that is holding up the lima, and it has to be bone dry since we can't able to re-reach this position later in mid-cap incisions. Minimal venous ooze we left behind. You can able to take the complete course of lima from the top to the till the bifurcation and beyond that also till diaphragm. And this is the complete course of lima after its takedown. And after taking down, we do a standard mid-cap incision, and we used our routine instrument octopus, and we didn't even have Felling's chest retractor. We used our thoracotomy retractors in the initial stages, and this is our final incision. We use that left side port for ICD drain and the camera port for mid-cap incision. So coming to the next case, we have done a robotic AST, 2 cases. And this is the standard operation theater setup inside our OT. We have anesthetist and DE on the head end, and we have a patient console coming from the left side of the patient, and patient side surgeon will be on the right side and the scrub nurse will be on the right side. Perfusionist team will be on the left foot end of the patient. So this will be the standard port placement. This is for both for AST and MER, it's same. We do camera port or working, we place the camera port, as I told earlier, it's just lateral to the nipple on the right side. 1 space above, laterally we place the left instrument, and 2 spaces below, more laterally we place the right instrument. And on the same rib space, more laterally we will place 1 working port for suturing and all. This will be the LA retractor or RA retractor. It will be 1 space below, more medially. So this will be the routine scheme how we do. After our cannula port placements, we peripherally cannulate femoral, and we dock the robo and we'll start initiate the CBP. And after that, we are docked and we'll go into the surgeon console. We open the pericardium, and I will show that videos. So this will be the AST. After your dock, we'll start harvesting the pericardium for AST closure. In this case, we used microbipolar and scissors. In lima harvest, we use scissors. We don't use scissors, we used only spatula. We go up to the thymus and we'll see the aorta, and this will be the first pericardial stitch we place at the junction of SVC-RA junction, and the second stage stitch on near the diaphragm to expose the IVC. We make a small stab incisions to come out through the chest for retraction. We go around SVC and IVC. Sometimes we'll get help from the surgeon side, bedside surgeon also. So we initially trial clamp. In this case, we first took sutures for CP. And we'll insert the CP needle. After that, we'll clamp. We check whether there is any. We usually look for LA appendage if it's coming in between the chitoot clamp. Once we got arrested, we'll open the RA. And we can see the ostium secundum AST there, where the vent is going on. And we start suturing from the routinely we start from the inferior aspect in the routine cases, open cases, but in robotic cases we start doing suturing from the 12 o'clock position. So I don't have that full video of this one. So this will be the final output once we have closed our AST. And this was the incision we made. Similar to Lima harvest, we used that right port for ICD. With another port, we can bring out the pacing wire. So coming to the next case, we have robotic. We have done robotic mitral valve replacement also. I am privileged to train under Professor Doug Murphy, who is a eminent robotic surgeon who has done around 4,000 to 5,000 cases. I had an opportunity to attend a workshop with him in the Ramaya University, Bangalore. After that, I had done my first mitral valve replacement. And the other things are same. The port placement and everything will be similar to the AST. This is our, we have done this case some around 5 or 6 months back. This case has full of lung adhesion, so we released robotically initially, and then we started our mitral valve replacement. So these are the lung adhesions we released. Once we are able to see the pericardium, we opened it and took pericardial stitches. Similar to the same, the pericardial stitches are always same. We will take on the one on the SVC side, one on the IVC side. In this case, we don't take CP sutures initially. We just cross clamped and directly give the CP. And we have taken out once we have once the heart is arrested. So we'll open the LA, and this is how we excise the mitral valve. We excise the anteromitral reflex, and we preserve the PML. And we start suturing from 12 o'clock position, similar in our open cases. The main advantage, you can see, we can go inside the LA and we can see what's happening inside, and we can take optimal bites. Once you have finished suturing, we'll size the valve. To place ICD in the dependent position and the right pleural cavity. So, adding one more feather to our crown, we are also happy to share that our team has first performed our India's first robotic mitral valve replacement in a government hospital setup. Though many central government institute has this one, we are the first one to do. I thank all my team for this. So, these are results. We have done around 75 cases. Most of the cases will be around, most of the cases are robotic Lima harvest with mid-cap CABGs, and 3 cases of AST, 2 cases of mitral valve replacement, and recently we started doing robotic there will be hypotension, sudden CO2 buildup. We don't hesitate to open any case, and some 2 or 3 cases we do have limohematoma, and there is a poor pulsatility, so opened straight away. So I thank every team members, previously Manoharan sir.
This was an awesome talk. And now the question and
At the outset, I'd like to thank Dr. Meenakshi Sundaram for organizing a wonderful CME program, especially on robotics. So hats off to Dr. Meenakshi Sundaram and the team. Congratulations, Dr. Abi, personally. You have done a wonderful job, and this is wonderful presentations too, with a lot of videos and stuff. So I would like to first argue and defer. One, you have told you, surgeons trained in government hospital, not sticking out to the government hospital and going out to the private hospital. That is, I would not like to accept that. And the growth, what you have achieved now is because you have stayed in government hospital. So you must definitely thank the government hospital. So don't say that, like saying that most of the service candidate who has left the government service joined in private. That I will not accept in this forum.
I'm not telling the service candidates. I'm just, it's one of the criteria.
Don't argue with me. Do not argue with me. You're a presenter. I'm chairing this thing. So the word you use, I do not accept that. Don't use that in any forum.
Okay.
Right? Okay. And the growth, what you have achieved is definitely huge and humongous, because I've seen you as a PG from 2016 to 19. And then you have moved on here. The God's grace and the console has come here. But before the console has come here, I would also acknowledge Professor Mariappan. He also knows, like, the console was sitting, we had a demo in MMC, and we are the few members who saw the Davinci in MMC and we approved it. But unfortunately, it landed in Omandurar. I just want to acknowledge the same also, because it was supposed to come to MMC. But good, this has come here to the good hands, and a lot of good people are doing. And another request from my side is, since like you are the lead in robotic, I also request the team members, the 3-4 members, to come up and get trained in robo, because it is a long way to go and it should not be monopolized, and everybody has to get into it and get trained. So that should be a teaching learning program. I request Dr. Meenakshi to make sure everybody learns and gets the thing, because the future of cardiac surgeries becomes a robo. And it's going to be, in the future, it's going to be very, very superior tool than opening up. And I want one answer from you, like, what is the duration of the surgery you have done for ASD closure? And what is the clamp time, and for the MBR, for the MBR also?
My overall time for ASD is around 4 hours.
That's a great time.
4 hours.
For the MBR?
MBR, since we had additions in this case, we did around some 6 hours. It
Excellent,
is like two surgeries we had.
6 hours, it's not a great much time. We perform in open also, we do 4 to 6 hours time it will take to close it and do the hemolysis and come out. Like, it's an excellent time lap. Definitely I should appreciate that. And the one final point is, like, how did you put the valve inside? Like, is there a separate incision you...
Which one?
For the MBR. The valve, like you have pushed it.
Valve.
Yeah.
I already
through which incision you have pushed the valve, and how big is that incision?
We have working port like this, sir. Coming.
What is the size of the port to push in the valve?
The incision we have shown, sir. That's the size.
Can you please specify in centimeters or millimeters?
Around, initial cases we had some 5 to 6 centimeters. In this, for both the patients, I didn't make separate incision for camera port. We just enlarged that working space, and in the top end we placed the camera port.
Okay.
Yeah,
3
centimeters. It's 3 centimeter.
Okay.
Mitral we placed on 5 centimeters.
5 centimeters, especially to put the valve in.
So
most of the times when we take the valve out, we will not know which is up and which is down, which should be on the LB side, which is on the LA side. So that is always tricky when we open up, because we'll have a holder by which we'll be very, very safe in. But here, when you go in, it will be very difficult to take a call, because you're putting the same valve like what we put in the open surgery, right?
Yes.
That's the same thing.
Same thing. Actually, what happened was he placed upside down.
No, this will happen. Okay.
So we take that.
It's a common mistake. Okay.
So rotated outside and placed inside.
So Aiden is Abath Pandavar Mari. He's just risking on all the issues. Right, thank you. It's a great job. No, you rectified it because you identified, right? That's a great job then.
Lila.
Okay.
Congratulations, doctor.
Thank you.
You achieved very nicely. The thing is, how many crafts you put? Because here, everyone is doing robotic assisted only. They are not doing robotic. But the advantage is, as you told, 8 times magnification. So we can see nicely compared with routine harvesting. Apart from Lima, would you have crafted any other vessels or not?
So we standardize only 50 cases, which we selected single vessel cases mostly, or hybrid procedures. The cardiologist would have done right side lesions.
At the time, we are not getting single vessel disease. Because almost all the single vessel, the cardiologist has crafted.
Yes, sir, that's what I am saying. Since if there is a
get the case.
Yes.
I am also trying to do, but I am not getting single vessel disease at all. So,
Cardiologists are very heartful to the surgeons in Omandarar, but not heartful to the surgeons in MMC.
Basi. One question. Another question is, when you do mitral replacement, you took only 6 to 7 switches only, la?
So we placed 10.
Placed 10. Yes, so much of gap was there.
No, since it's magnified, magnification.
Like that, okay. Then you put CP cannula, la?
Yes,
you
sir.
put CP cannula. Only insert CP cannula, you remove it, la? They approximated the switches or not?
Yes, sir. We will approximate once we have done our venting after the cross clamp is removed.
How you went? That's what I am asking.
There will be a hole in the aorta, so we will DR through that one. We allow it to bleed.
You remove the CP cannula. Out.
Yes, sir.
Then just away you went through the aorta.
Yes, sir. Without active suction, we ventilate. Beat and ventilate.
Actually, that's not good. The aorta may tear up, the hole may become bigger.
No, it's not our routine, sir. We tried both. In the another case I have showed, we have taken the sutures and we have placed in a CP cannula. They place directly, we are given.
No. See, he's asking like routine, you place a purse string and put a catheter. It's a different one. What he has shown is the first one. He is asking about the second case. You put in the needle without any bite.
Like that also.
You pull out the needle, the hole will close again. So proper DRing is not done. That is his question. Proper DRing is not done.
Actually, recently we went to Velammal, we went to Madurai. There also, the case, they did one endoscopy assisted. They struggled because they removed the vent cannula. Then they struggled, the heart does not come out. They struggled a lot. After half an hour only they come out from the bypass, something else. So better to put a cannula
proper
inside.
DRing should be there.
Do proper DRing and do the job. That's what
So, one more thing. Yes, sir.
Congrats.
I will just clarify that thing also, sir. Since we are insufflating CO2 into the field, there won't be any much O2 inside the field. So we are somewhat later. So we will take up your opinion also, sir.
Any other questions from the floor, please? Yeah. Dr. Ranjit.
Multi-vessel CABGs, we are starting bilateral memories and first grafting of the OMs.
Diagonals.
Or diagonals. Vein grafts, as of now, we are not planning.
Actually, as you told, we are struggling because of the disposable cost. Okay, but recent machine has come. We can reuse it for nearly 62 times.
Which one, sir?
I forget about the name of the machine. Only Da Vinci, next one.
The mantra.
The mantra,
yeah, we can
recently
reuse
I saw in Apollo. I also tried.
No,
but they can use it for nearly 62 cases.
Yeah, what you're saying is correct. Like Mantra as an Indian brand, they have a head office in Delhi. I have met the chairman personally.
Not only that, it is not covered.
You can use it for 50 cases. Yes.
Just we can sit.
Yeah, I have seen
we
that.
can handle.
So in Da Vinci, we can use the same instrument for around, it varies around the instrument. 10 times, and some instruments we can use it for 20 times.
Yeah, we can furrow on the Da Vinci also. I know the code to break it. we know to break it and we can use it for 25 times. I don't want to disclose in this forum. I'll tell you later. Yeah. Over to Ranjit.
So good morning, sir. Sir, this is a wonderful program in government setup, sir. So it should be continued in a good manner to the benefits of the public. My question is same like what Shivan sir asked. What is the learning opportunities and what is the learning curve to the other surgeon?
This question I think Dr. Meenakshi should answer.
Yeah. Anyone, sir?
We are in the process of
sir, second question, sir.
Yes.
Sir, do you have any future plan for expanding this program further in the government setup? Thank you.
For the first question, we are in the process of starting a full-fledged training program for the robotic for the surgeons who are aspiring for robotic surgery, not only robotic cardiac, other departments also. Here also we share, we don't use it for our own. Weekly we get 2 or 3 cases alone. Okay, so our management as Dean sir also is very much interested in taking up the robotic program in a higher way, and department, our health secretary and ministers are also gave assurance, and we are in the process of starting a training program.
Doctor, when it is Doctor, Doctor, when it was installed itself, they permitted us to come and work there. But our people not coming here and learning, that's all. Because we feel that we are having time, we are not having time like that. See, if you want, you can go there. Well, if you want, you can get permission from your dean and the director, and you can come and learn, operate here. No issue.
To conclude, I'd like to say a few words and we'll close up the session. I think Dr. Meenakshi is struggling hard to give the proposal to the government to go with the training institute for these robotic surgery, especially cardiothoracic. And the mentor would be like Dr. Rabi, because he has done so much of cases, and the second would be Erlan, who has been assisting for so long. So I also beg to differ with Dr. Nandakumar, saying that yeah, of course you have to do cases, but training is also a must. See, we cannot depend on one surgeon or two surgeons, because it's a government institute. The cost is going to be very high to install the Da Vinci in all 3-4 centers around the Tamil Nadu. See, in Chennai, so this one center will be, I think, will be helpful for other interested surgeons to come and learn here. So as soon as he submits a proposal to the secretary, under secretary, as well as the chief secretary is planning to do it. So we'll be taking on board 2-3 surgeons from various government institutions alone, not in the private this thing, but to debit for 6 months or 1 year to get trained. And after you get trained, you have to do 10-15 cases or 25 cases, whatever the Da Vinci says, then you become a mentor. So once we have a lot of mentors, at that point of time only we can purchase more machines like this Da Vinci, because it's very expensive. If it's going to be mantra, it's very less compared, because 1/10 of the cost. Then you will be the mentor and you will be training people. That is in the pipeline. I think he'll definitely accept what I'm saying. So soon, we'll definitely launch a program by which every surgeon will be, interested surgeon come and learn here. Thank you.
We'll move on to the next.
Okay.
Sir,
Congrats, doctor.
One more question, sir.
Thank you, sir.
Sir, one more question. One more question.
I congratulate my friend, Professor Meenakshi Sundaram, sir, Abhi, Elilan, Rakesh, and other team members. This is an excellent session. We used to call Meenakshi Sundaram sir as a VSR surgeon. He is expert in VSR. Now he is an expert in robotic surgery. Valthukal, sir. Thank you.
Sir, I have one question, sir. So, first of all, I congratulate the entire team for making multi-speciality more popular in robotics. So, thank you so much for that. With regard to this technique, this is more of patient-centric, right? How early may you mobilize these patients? And do you have any fast tracking of these patients? Any plans?
Yes, sir. Initially, we followed routine protocols like open for the initial some 10 or 20 cases. Once we have gained confidence in our post-op setup by dealing with the minimally invasive surgeries, we started extubating patients by around 6 hours in mid-cab, robotic assisted mid-cab. And MER and ASDs, we didn't done fast tracking, but we extubated by around 10 hours or so.
Last 4 or 5 CABG cases, we are discharging on the fourth
POD.
Thank you all.
Thank you.
So we'll move on to the next session. I would like to invite Professor Saravakrishna Raja sir and to speak upon the topic addressing small aortic root profile, surgical challenges and management strategies. And I would like to call upon the stage Professor Nandakumar sir and Dr. Vignesh.
ஒரே ஒரு வீடியோ தான் இருக்கு. A very good morning, one and all.
இது கனெக்ட் பண்ணலாம் சார். ஆடியோ போட்டிருக்கீங்களா சார்?
அது லாஸ்ட்டில் ஒரு வீடியோ மட்டும்தான் இருக்குங்க. கனெக்ட் பண்ணுங்க.
நல்லா கனெக்ட் பண்ணுங்க.
இது ஆடியோ வேணாம்.
A very good morning, one and all. A wonderful discussion by Dr. Prem and Dr. Abhi. I thank you, Omandura team, Dr. Meenakshi sir, for giving the opportunity. I am going to discuss about managing a small aortic root. So what is a small aortic annulus? Regarding the annular area, less than 400 millimeter square, or regarding the surgical annulus, less than 21 mm is said to be a small aortic annulus. And in this, the attachment of the aortic valve will be like a crown-shaped annulus. So covering that area useful for TAVI implantation, and you know that VA junction, which will be essential for us to put a prosthetic valve, and the determination of VA junction will give an idea about the aortic annulus. Patient process mismatch. So this concept has been introduced by Rahimtullah in the year 1978. So when to say a PPM? In the effective orifice area of the valve, what we are going to implant, it is too small for the body surface area of the patient. It can be identified by the indexed effective orifice area. So comparing with the biological and the mechanical valve, you can clearly able to say that the biological processes will have a reduced effective orifice area than mechanical processes, and there will be an index effective orifice area can be measured from each manufacturer, so that we can able to put a proper sized valve. The effective orifice area divided by the body surface area will give an idea about the indexed effective orifice area. It should be more than 0.85 centimeter square per meter square. There will be a nomogram chart for each and every manufacturer. So in this, for a 19 sized valve, the effective orifice area will be 1.3 centimeter square. So we can match the body surface area, and that should be in the blue chart. So we should try to avoid lesser effective orifice area, and definitely we should avoid the red zone. The same thing applied for the mechanical valve also. So in the preoperative period itself, we can make a decision. So we should do a thorough evaluation, and we should measure the annulus size, and we should also compare with the nomogram chart with the valve what we are going to implant. And beyond that, the perioperative assessment after the thorough valve excision and the annular debridement, that gives exact sizing of the matching of the prosthetic valve. So what our aim should be? We should provide, the patient should have a good valve hemodynamics, and there should be adequate LV mass reduction, that is reverse LV remodeling from the LV hypertrophy because of severe aortic stenosis, and we should expect the reduction of turbulence at the valvular level, and we should also note a gradual improvement in ejection fraction post-surgery. So there are a great number of meta-analysis data showing the existence of PPM in the early, mid, and long-term aspect that may cause morbidity and mortality if we put a small valve. And this recent meta-analysis study showed that there will be associated with poorer long-term outcome with putting a smaller valve, and any degree of PPM will have its own effect. And this study has shown that up to 10 years the patient can survive, but there may be a little bit of exercise tolerance, but after 10 years slow pannus formation may lead to a reduction in the day-to-day activities of the individual. So the PPM, why it is important? Because it is associated with higher risk of cardiac death in the postoperative period. Putting a small annulus, small valve will cause a hemolysis even, and the patient may get admitted repeatedly because of cardiac failure. And even putting a small valve, small annulus, small valve, the patient may need to have multiple aortic valve intervention because even a small pannus formation or a small clot, a patient may need to get readmitted. And if you put a smaller bioprosthetic valve in according to the patient body surface area, the patient may need to have a reintervention. And putting a small valve in a small annulus with a patient on a patient with a heavy hefty patient, the patient will tend to have early valve degeneration. So when to put a small prosthesis? The patient is a small individual, the elderly, the longevity of the patient will be less. Yes, definitely we can go with a small prosthesis. And there are a wide variety of choices in dealing a small aortic root. First of all, we can definitely put a valve at the supraannular level. There are stentless bioprocesses are available. The sutureless processes are also available. And TAVI is one of the methods which we can able to overcome the small aortic root. And the Ross procedure in children, the floating Bentall other than a conventional Bentall, and finally the root enlargement. So we will be discussing one by one. So supraannular portion. So what is the added benefit in placing the valve at the supraannular level? This is nothing but if you use a pledget facing on the ventricular side, we can able to put a 1 mm valve bigger. So likewise we can get away from the situation where we need to put a smaller valve. And what is this chart has shown the advantage of placing the valve at the supraannular level. There will be reduction of PPM and the reduction of pacemaker implantation also lesser if we put a valve at the supraannular level. So what is the drawback of putting a valve at the supraannular level? Yes, there is a possibility of obscuring the coronary ostium. So if we put a valve at the intraannular level, there is nothing to worry about the obscurance of coronary ostium. But if we put a bigger size valve at the supraannular level, we need to worry about the blocking of the coronary ostium. The next option will be a stentless bioprocesses, and this is the freestyle valve from Medtronic. It will be available to place at the subcoronary level so that we can reduce the gradient in the postoperative period. This is another option available. Then this is a perceval valve. This is a sutureless bioprocesses. It is the data shown that it is found to have a lesser postoperative gradient, and it has been indicated for the patient with a small aortic root. And this method, even we can peroperatively we can reduce the cross clamp time after removing all the cusps and after thoroughly debriding the aortic root. We can able to put this sutureless bioprocesses. Then of course TAVI. So with the introduction of TAVI with the self-expandable and balloon expandable stents, TAVI is very effective in a small aortic root, but it should be very carefully placed. That needs a technical challenges also, because the possibility of pacemaker implantation because of improper placement will be there around 20% after a TAVI. Then coming to the Ross procedure. Suppose in a children with aortic stenosis, definitely we can go with the Ross procedure because the pulmonary autograft what we are using will grow with the individual. Then floating Bentall. And this floating Bentall, what is the advantages? So this is the Valsalva graft what we will be using for a Bentall. If we place a valve at this Valsalva graft level, we can definitely increase the valve size of 2 to 3 sizes bigger than the conventional Bentall. So it is a viable option for a patient with small aortic root. It is floating Bentall procedure. And this is the apicoaortic conduit. And this is the last reserve. Suppose the patient with small aortic root who underwent multiple AVR, a patient coming for the 4th time, what we can do is we can put a apicoaortic conduit. It is nothing but it is fixed to the left ventricle, left LV apex, and through the valved conduit, the blood from the LV is pumping into the aorta. So it is the last option, and I don't think any of one doing this method, but it is reserved for the redo surgeries of multiple times to the patient with small aortic root. Then he will be discussing about root enlargement. So coming to the root enlargement, there are two methods. One is posterior, and the other is anterior. Coming to the posterior method, there are Nix, Manugian, and the recent Boyang. In anterior enlargement, the Conoraston. So why there is a need for root enlargement? As we know, we need to avoid the PPM. Placing a smaller prosthetic valve for a larger body surface area is a serious iatrogenic disease. The patient used to have repeated admissions for hospitalization in view of LV failure and because of increased gradient. Our aim is to provide a better hemodynamics, and also we need to reduce the LVOT obstruction. I will be discussing in short about the Manugian method and Nix. In Manugian, the incision will be at the commissure level of the LCC and NCC. In Manugian, we can even go up to the anterior mitral leaflet. In Nix, through the non-coronary sinus, we can able to upsize the annulus by one valve size, whereas in Manugian, we can able to increase the root size even by two valve sizes. And we can use a Dacron patch or a bovine pericardial or autologous pericardium treated. That patch should be a teardrop or a diamond-shaped patch. So with this technique, we need to repair the anterior mitral leaflet, and the same patch will be used to close the aortotomy like this. And the main drawback of this Manugian method is mitral regurgitation. So we need to repair the anterior mitral leaflet properly, and if LA has been opened during the procedure, and that needs to be addressed to avoid the postoperative bleeding. Yes, it is possible to implant a valve 2 sizes larger with the help of Manugian and of course with the Nix procedure. Next, Conoraston, it is also called as aortico-ventriculoplasty. So with this procedure, the patient is presenting with supraannular, valvular or subvalvular stenosis. It is a wonderful procedure because it wide opens the LVOT and the RVOT. So this is the anterior approach. Here the incision will be extending in between the right coronary artery and the LCC-RCC commissure. So with this incision, we can able to open the LVOT and RVOT also with a separate incision. So we can definitely put a valve of 2 to 3 sizes from the aortic annulus. And the closure of this Conoraston will be technically challenging. We use double patch technique, and you can able to perceive we are having a 2 patch. The inner patch is also called as aorticoseptal patch, and the outer patch is called as RVOT patch. So with this inner patch, the septum will be closed, and after that the increased valve to be placed, and this inner superior aspect of the patch will be used to augment the aortic annulus and the sinuses, and this outer patch, the outer patch will be used to close the RVOT. So in this way we can do a Conoraston, and this way we can use to close the. And what is the drawback of this Conoraston? We should be very careful to avoid injury to the right coronary artery, and there is also the possibility of injuring the membranous septum with this approach, and we should be very careful enough to close the VSD. And what is the main advantage is the patient presents with subaortic stenosis. Sometimes we may need to, usually in a small aortic root, we may concentrate on the aortic root, but sometimes even after the procedure, the patient will used to have a persistent gradient. At the time, if we do a repeat echo, we could have just missed the hypertrophic cardiomyopathy, which is a definite cause for a subvalvular stenosis. So this Conoraston will be a viable option for a patient with valvular and the subvalvular stenosis. And it's also a useful method to do a myectomy during the HOCM. So what is the main advantage of Boyang, and are we still doing the Nix and Manugian? So Nix and Manugian, yes, with the sum of technical challenges, we can upsize the aortic annulus by 1 or 2 valve sizes, and with the advent of this Boyang, yes, definitely we can put a very bigger valve. we can increase the valve size by 2 to 3 valve sizes. So how it helpful, and what are the techniques we can able to do in this Boyang Y incision. We can start the Boyang with a complete aortotomy or a partial aortotomy. And originally the Boyang used to do a complete aortotomy for a regular Boyang and a partial aortotomy for a redo surgeries. So this is a Y incision. This is the posterior enlargement. Here, with this technique, we can enlarge the posterior wall of the aortomitral curtain, and we have to make sure the left side we have to limit up to the membranous, up to the muscular level. On the right side, we have to limit the Y incision up to the membranous septum level. So with this, we can wide open the aortomitral curtain and the posterior wall of the LVOT. And the options available for the enlargement are Hemashield Dacron patch, bovine pericardial patch, or even the autologous pericardium that was treated. The first stitch to be taken at the level of the left fibrous trigon, then gradually it will be coming towards the right. The stitches should be hemostatic, and this is called the transition suture. So from starting from the right side of the annulus, we should be transitioning towards the aortic sinus. So it should be very watertight, and any bleeding should be addressed on table. And this is very important, the sizing. We can use a bigger size bovine valve or even the mechanical valve. Why sizing is important? Because after enlargement of the posterior root, and we have to mark where we need to take stitches for the newly formed annulus. And it should be a dome shaped, right? It should be a dome shaped, and we have to make sure the adequate part of the patch or the bovine pericardium has been utilized for the enlargement. And you can see the assistant is pulling the patch up. So we should not make this level of patch to crumple, because if it got crumpled, it may end up in struck valve in the postoperative period. So this we need to take care of. And another thing, we should not mark too low, because if we place stitches too low, what happens? The valve will place little bit towards the posterior, and that may cause obscuring, or that may cause obstruction of the right coronary ostium. So these are the two important points we need to observe before proceeding valve stitches. And after putting a patch, say Boyang advising a 3.5 centimeter width of the patch to be essential to increase the valve of 3 to 5 sizes. And this end of the patch should be trimmed like a triangular shaped or a tongue shaped, and the distal part of the posterior wall of the aorta should be incised longitudinally, and this should be incorporated with it to wide open the posterior root. So this is, in this way we can take stitches, and with this posterior adequate enlargement, and there won't be any tension among the suture line, so there won't be any bleeding as anticipated, even with like aortotomy. So this is the patient what we did. We used the bovine pericardial patch, and we took stitches as described from the left fibrous trigon and proceeded with towards the right fibrous trigon. So here, so we use this. So stitches on the left side. Then gradually we proceeded towards the right side, and we make sure towards the transition zone, like there won't be any loose stitches. So after the adequate posterior root enlargement with aortic root technique, we placed Miltonia valve, bileaflet valve, and there was no any bleeding in the postoperative period. So the take-home message: the PPM exists. Most of the time we used to forget and we used to put a smaller valve. The patient used to come in the postoperative period. Patient may get discharged, but the lifestyle of the patient will be less, and the exercise tolerance will be less after the surgery. and we never put a bigger valve into the narrow annulus because the possibility of annular rupture will be there, and the possibility of on-table coronary obstruction may also be there. And the Boehm technique is very much reproducible and is very effective. And we should always rule out the subalveolar pathology or LVOT obstruction before proceeding with posterior root enlargement. And we should also know there is no one technique fits all patients, so it should be modified according to each and every individual. And though root enlargement is very rarely done, and it should be always in our armamentarium. Thank you so much for the opportunity. I thank my team, Dr. Kavita, Dr. Shiva, and the whole the perfusionists for being with me, because we started from the scratch and we can able to do our daily cardiac surgeries. Thank you so much, and thank you Meenakshi Umandura team for the opportunity. Thank you everyone.
Thank you, sir. That was an awesome presentation. We will go on to the question and answer session.
So wonderful presentation, sir. Can you explain the suture material you used, the size, the needle size? Whether you used 2-layer sutures or single layer?
Sir, we used 4017 mm needle. We used a single layer technique only. Since we are widely opening and we are giving adequate room, there won't be any tension among the suture line. It won't bleed.
Okay, sir. Any glue, sir?
No, sir.
Okay, sir. Other than pledget is placed inside the graft or outside the graft, sir?
Outside the graft.
Outside the graft. Any questions to the floor?
Yeah, excellent presentation, Saravanan.
Thank you, sir.
Can you describe about the patient, like what was the preoperative echo finding, like what is the annular size, and what was the valve size you have put, like how much big you have put?
Yeah. Elderly patient, lady, 64 years. The preoperative echo was 16 mm, and the before surgery it was given as 19 mm. Actually, we are in the mood that at least we can come out with a 18 mm valve, AP valve, Miltonia, or put a 19 mm valve, like that was in our mind. But anyway, we explained the patient that there is a possibility of a root enlargement since initially it was given as 16 mm. So we kept the mind open. We prepared, we excised the valve. It hardly admits a 16 mm sizer. That's what we used to follow, even though with the adequate preoperative evaluation, which the strict measurement with all the excision, with all the root debridement only, we can able to adequately size. So once it is not fitting, the body surface area is much more. This according to this patient, the 21 mm is the adequate valve which we need to implant. So we proceeded with root enlargement.
So as per the nomogram, it was 21 millimeters. Yeah. Okay, so usually we'll do iotogram before proceeding any case for the thing.
Pardon, sir?
Iotogram. See, it's a small annulus. We'll subject the patient to iotogram to confirm what is the size instead of going on table. So whether the iotogram was done for this patient or only the echo finding was noted and the patient was...
Sir, echo was done on this patient, and we used to do iotogram also in specific individuals where the patient is having the post-stenotic dilatation and we want to rule out whether the patient is having aneurysmal aorta or not. Yeah. In such conditions also, sir...
The small aortic annulus also, we do iotogram for...
Actually, iotogram, they couldn't measure the annulus properly. Compared with the echo, comparatively echo is better than iotogram.
Yeah, but to
that's
confirm
what
it, like...
I also checked in private hospital also. They given 2 cases some measurement. Definitely the echo measurement is better than the iotogram.
So as per the recent echo, it was 19. But it did not admit 16 was the on-table finding.
It is always a subjective variation upon the cardiologist, sir. So on-table assessment always give a clue.
The echo finding differs from cardiologist.
Most of the time we don't get an exact annulus size by echo.
That's true.
Most of the time.
Most of the time.
Sometimes they may say 18, but we can put 21 valve.
Also, it's always
sometimes they may say it's bigger annulus, but we can't introduce even a 19 valve.
Not because of cardiologist. Actually,
we need to do a personal echo. Nowadays, our people are doing personal echo on their own. They are sizing the valves before sizing the annulus before they are going for surgery.
Yeah, for our case also, Shiva did the day before and told, sir, definitely it is not 19. We should be somewhat alert. Where is Shiva?
So what was the annulus? 16 only. Okay. Fine. And the last question would be like, see, I mean, you know, like I always put the pleasure in the aortic side, unlike others do on the LV side. So I beg to differ with you. Like, if you're going to put the pleasure on the aortic side, you might compromise the valve size of 1 or 2 millimeters, and the chances of coronary ostium occlusion and all.
Yes, yes.
I have done cases in 4-digit, not 2-digit or 3-digit. I'm talking like more than thousands and thousands of cases of AVR and DVR. Touched. None of the cases I have experienced kind of putting a small size valve or any kind of a coronary occlusion. So I don't know, because I'm just throwing a light to the juniors or the budding surgeons, like the concept of putting the pleasure on the LV side or aortic side. I personally feel you can put the same size of the valve when you're going to take the pleasure on the LV side, and it's not going to have any kind of a kink effect or a compromise on the coronaries. That's one difference. Thank you.
Sir. One more question.
Yes, no, not one more question. Just a comment.
Floating Bental.
Yes, sir.
Floating.
Yes, asked, he is answering.
I just have a doubt. In this floating Bental, you are placing the valve in the sinus part.
Yes, sir.
But below that thing, that's the graft is narrow. How can you reduce the gradient by placing a valve just above below the valve that is a narrow part?
Yes, sir.
You can place a bigger size valve in sinus part. That doesn't matter. But the LVOT, it's narrow only.
Sir, wonderful question, sir. Sir, actually, the thing that is causing the reduced index effective orifice area is we are utilizing the aortic annulus part with the outer ring for the most part of it. Here, what we are doing is we are suturing the graft with the aortic annulus. If the annulus size is 19 mm, we are keeping the same 19 mm. We are not reducing it to 16 mm.
See, whatever it is, you have to enlarge the LVOT outlet. Unless you increase the LVOT, no point in putting floating valve and all. For your satisfaction, you may feel that because this valve is inserted. But unless you increase the LVOT, you won't be achieve the target. That's all.
LVOT enlargement is the prime modality.
So, what it is, the Poyang technique is the better technique, best technique. You are not mentioned about the Noonan's technique. Instead of Noonan, then Poyang technique is better. We can accommodate at least 3 to 4 sizes bigger size valve. We also recently done one case in outside for redo cases. Very good output. Another thing is, what I want to tell is, when you put a supraannular position, you told LCA or RCA coronary may be occluded. Actually, strictly what they say is, they will take sutures in the left coronary and right coronary. But in non-coronary side, they will take supraannular stitches. Non-coronary side only, they will take supraannular stitches. So there won't be any possibility of coronary occlusion. Okay. Thank you. Congrats.
Sometimes even after placing a bigger size valve, like 21, after post-operatively we are getting gradients. Any reason?
And we should match the index effective orifice area before implanting the valve, it seems, sir. So, as per textbook, 21 mm, less than 21 mm valve will cause a gradient. But in our Indian population, the 21 mm appears to be a bigger valve. Even most of the patients will be, we can build out with a 19 mm or 18 mm valve.
Basically, our body surface area is a little
very less
lower than the
Western standards.
And just one comment. And so regarding Shivan sir, you asked the supraannular and the intraannular. Now, whatever he described was, it's actually for TAVI, not for surgical aortic valve implantation. Where the valves are not removed, the marker in the TAVI valve, previously they used to implant at the lower level where they found pacemaker rates were higher. Now they are implanting a little higher but they have to measure the coronary distance to the annulus. So that's where it happens, not for the surgical valves. Whatever in the picture also,
sir, in surgical...
Here, whatever picture he has posted, showed it, it's for TAVI. That valve is TAVI valve, not surgical valve. I don't think it matters. Aortic, supraortic or the annulus stitch doesn't matter for us.
But if we place a bioprosthetic valve, placing at the supraannular
anyway, you're
level,
going to take it in the annular level. When stitches are in the annular level, or you're going to take it on the patch or the in the sinuses only. You're not going to take it on the LCA or the RCA side. You're not going to take it above the annular level. You're going to take annular level only.
Yeah.
So it's unlikely to cause coronary obstruction or pacemaker, increased pacemaker implantation.
Okay.
For surgical valves. This is whatever you described. Your picture also is TAVI valve. It's not for surgical valve. But very good detailed presentations, good overview. Thank you.
Thank you. Thank you, sir.
And one more question. The forum can also answer.
Yes, sir.
We are the most commonest size aortic, as far as aortic is concerned, we are 19 mm.
Yes, sir.
So, are we underutilizing the root enlargement procedures or?
No. I beg to differ, Meenakshi. We are not using 19 as a common valve, 21 is a common valve.
Whatever it is, 19 or 21, as you say, compare. What?
Already Nandamar has answered. Our body surface area, Indian patients, around 19 to 21 is all right. That's all.
See,
sir, we only do root enlargement if we are not able to insert
Western,
16 size walls. Sir.
Western standards 23 and above, even 21 they are saying it as.
Then why are they producing?
Sir, even though it is a Western or Indian population, the measurement
our
of
population,
company is producing 17 size valves also for an adult.
They are surviving.
Why they are producing 17 size?
That is not for the adult, that's for the pediatric.
Sir,
that's not for the adult, that's for the pediatric.
19 is for adult or pediatric?
No. Anything less than 21 is not supposed to do it. You have to do a root enlargement. Because we are not comfortable on root enlargement procedures, we are putting a 19 valve. That is the answer.
Okay.
That's what I wanted. We have to.
Sir, may I know your experience in root enlargement, sir?
I haven't come across any cases like I'm putting less than 21. So I tried to push it all cases. I can bet you, I can show you the literature, the cases what I have done.
Without root enlargement, you can
with the name and the IP number and date of admission and discharge. I have put almost 95% of the patients 21 or 23.
Without root enlargement?
Yes, of course, yes. Of course, absolutely, yes. I haven't done not even a single case of root enlargement. I also accept it. I haven't done any root enlargement procedures, but I have not done less than 21. Hardly few cases, and that too, the nomogram says 16. Nomogram, as per the pump technician, we ask the pump technician what does the nomogram says. It says like it's 16 or 15, but we try to push 19. Even after putting 21 or 19, the patient will have PPM. Post-operatively, the echo will say like PPM is high or the gradient is high. The reason is we are not seeing what you showed the chart, no? The orifice, the effective orifice area, that is the one which is going to catch up the patient post-op period showing. So most of the patient have LVH or outflow tract muscle will be hypertrophied. And that will come, you said, no, like the LVOT or the muscle hypertrophy, if it's not going to get regressed, then the gradient will be very high and the patient will have some kind of a PPM. But 21 or less than 21 is considered as a small aortic valve. That should be the take-home message.
And most of this root enlargement is for, it will be useful for bioprosthetic valve. The mechanical valve will be able to get away with without root enlargement. Even in a smaller root, apparently a smaller root, we can tilt it and tilt the valve and implant because the obstruction, we can get away with it. But bigger bioprosthetic valves, it's definitely you'll need some form of root enlargement.
Recently, we are using Hegar's dilator for placing a little bigger size valve. After placing a sutures, we put a bigger Hegar. For example, if it's admitting 19 sizer, we can introduce 21 or 23 Hegar's dilator, and then we can place a bigger valve one size up. I saw that discussion was going on in Indian Academy of Cardiothoracic Surgery group by Hamdule.
Okay, sir.
So after that thing only we are using HEGAS for dilating the LVOT.
So
Cardiologist can dilate the LVOT and mitral with the balloon.
Expandable and
Definitely we can dilate
Why
it with
not
the
we dilate
HEGAS.
with the HEGAS dilator?
Dilatation of valve is different from dilating the aorta. See, what the point here is to check appropriately what is the size can be pushed in. That is the reason they are putting a HEGAR. See, if the HEGAR can admit 21 or 22 millimeters HEGAR, then the 21 valve can go in. But we are not dilating the aorta by putting in the HEGAR. It is just sizing appropriately. I think that is a real concept.
And surgically
we are not dilating or we cannot dilate. That is my personal.
I'll like to add one more point. As you said, our retired professor, sir, Manogaran sir, used to dilate the annulus with tubs. We use for mitral, closed mitral.
We used to use a right angle also.
That is not the gross dilatation. Just we can, if we are able to increase the size of valve by 1, it's better for the benefit of patient. So, yes, HEGARs, it is just dilating the annulus. That's all.
There is no more tubs here. If put appropriate size, like the chairpersons can conclude the session.
Even if it's dilate, one side will back to same size only. Because it is not an annulus. It's not a commission. So there is no point in dilating with the KAGAS and all. That's all. No use.
Last question.
Anyway, conclude. Okay, doctor.
Sir,
Congrats,
Thank you, sir.
doctor.
It's a wonderful presentation.
Sir, one more question.
Sir,
during my PG days, Anda sir used to tell, take out the list of cases we have done with 17 and 19 valves, aortic valves. And we have taken for past 8 years or so. And we have done around 60 cases. And I am able to contact 20 to 30%. We have a mortality of around 10%, I think. And of the 30%, though their gradient are high, they are asymptomatic. What's your comment on this?
See, the echo is always subjective. We have already told you. See, it is a subjective thing. Number one. And number two, the patient LV will get remodeled post-operatively. That you have to accept it. Right? So, when the patient is getting the drugs and patient is, when the time goes on, when the wound heals and the LV gets remodeled, these symptoms will be less. But as per the echo, the gradient will be high in the initial stage. After 6 months or down the line, 3 years or 2 years or 5 years down the line, the gradient will definitely come down. But later, after 5-6 years, the pannus will start forming. You know, all those pannus, once the pannus starts forming, then the orifice, effective orifice area comes down. And after 10 years or 12 years post-valve replacement, because of the pannus, again the gradient will go up. It's not because of this thing. So there is a lot of things going on. Nature is doing a lot of work inside. We are not seeing all these things. So we are seeing only a 2D image, a black and white image. We are not gifted to see what's happening inside as a 3D. So it varies from patient to patient. And the drug compliances, everything. If the patient put on weight, I like to add this also. If the patient weight is around 50 kg, we're going to put as 21 or a 19 valve. And if the patient post-operatively after 3-4 years is going to get more weight, is going to be more bulkier, then it's going to be a mismatch. Then the patient will have symptoms. Right? You accept that? So patient weight at the time of surgery is different, and at the end of 3 years is different, the end of 5 years is different. So lot of contributions, a lot of factors are there.
The patient gradually starting developing symptoms after 10 years.
In his presentation himself,
if you put a smaller valve, the symptoms will develop earlier.
The study also proves the same thing.
If you put a bigger valve, the symptoms will develop after 20 years.
CPM manifests only after 10 years.
Only after 10 years, as we don't enlarge the LVOT, we are enlarging only. It's again going to show the gradient again.
Actually, no, see, that is the reason I'm telling you, any valve less than 21 millimeters or 21 mm valve you're going to put for, even in Indian scenarios, it's going to cause some kind of a echo-wise gradient high and echo-wise PPM. There is a scenario called echo-wise, the patient is in PPM. But clinically, patient will not on PPM at all. We have seen couple of patients, and I'm getting reference from Tanjavur also, and Coimbatore also saying that you guys have fooled the patient, you have put 19 valve. I say, patient is happy. patient is able to perform the activities. Patient does not have any symptoms. But he used to claim like after 5 years or 10 years down the line, patient will go for a PPM. At that time, we're going to do a surgery, redo a surgery. It's going to be more complication, more morbidity, and more mortality. That is the reason. One time, good job. If you can able to push 21 with a native thing, push it. Otherwise, go with the Saravnan's concept. Do a root enlargement and put a 21 or 23 or 25. You'll be happy.
True.
Right? Thank you.
This is what I asked. So are we underutilizing root enlargement?
Yeah, of course, we are underutilizing root enlargement because my guru did not teach me, and I am not teaching my juniors because I'm literally afraid of doing a root enlargement. I'm admitting in this forum, I don't want to do a root enlargement because the post of complications and the bleeding is totally high, and I don't want to have any mortality or a morbidity. And personally, I'm not putting any size of valve which is 17 or a 16. I'm putting 21. With very, very rare scenario, I'm putting 19 valve. So 21, 23 is my maximum number of AVRs or DVRs which I have put. So I'm comfortable. And as Mani said, like I'm not putting a lot of tissue valves or any bioprosthetic valve where it requires a root enlargement, because we don't come across that kind of a patient here, because this is not a pediatric setup, it's an adult setup. So I think like I'm comfortable with this. And to answer Meenaksh's question, like 19 is absolutely for the adult patient, it is a smaller size valve. Anything below 21 is small size valve. We have to go for a root enlargement.
Root enlargements.
Thank you, sir.
We encountered one case, the coronary arterial obstruction, right side. Sometimes the right coronary ostium is sometimes may be high, sometimes be low, or sometimes be very pinpoint. One case is after placing the 21 valve, we encountered the obstruction in the right coronary because that opening was very low near to the annulus. So in that case, we removed the...
Where was the pledget kept? In the aortic side or LV side?
Aortic side.
So routinely you put it in aortic side?
Sir,
or routinely?
for that case, we place ventricular side only. Sir.
Ventricular side. Why you want to put a higher size valve?
Sir?
You want to put a bigger size valve, you put the pledget in the LV side? Or routinely you put the valve?
Routinely we put, sir.
Okay.
But after placing the 21 valve, we encountered the obstruction in the right coronary artery because it was very low, that case. So we removed the pledget, then just we directly closed with the proline. That place.
No, pledget is not going to obstruct the coronaries.
Sir?
Probably there's
not
some...
pledget, in the opening of that leaflet we rotated.
Say like instead of putting 19, if you put 21, the coronary will get occluded.
Okay.
Is that the question?
What is your question?
What is your question? See, instead of putting a 19 size valve, we have put it a 21 size valve. Because since there is a 21 size valve, the right coronary got occluded.
Yeah, that's it.
No, that is absolutely myth and will not happen if the stitches are properly placed and the knots are properly secured. Definitely you will not occlude the coronary ostium unless there is going to be a bioprosthetic valve or a tissue valve where there is be a bigger one. But for the mechanical valve, the cuff is almost similar for all the companies. I don't want to name the company name. Touchwood, I've used 3-4 companies right from 2010 to 2025. None of the companies' cuff have occluded the right coronary ostium. Probably maybe a loose stitch, or you have not debrided properly the annulus by which this thing has been placed a little bit higher side. So that's the reason it has been occluded. If you go back and if you clear the annulus properly, it will properly sit and it will not occlude the RCA. See, pledget is an LV side. You pledget see, what this question is, pledget is an LV side. It is not in the annulus side.
Sir, shall we conclude with it? Go for lunch.
Okay, we will go for the last session.
Sir, it's a wonderful presentation, sir.
Thank you.
Here
last question from Dr. Vignesh.
We'll finish it.
We will okay. Conclude.
Conclude.
Okay. Or I would
Thank you, sir. Thank you.
10 minutes. Can we have a 10-minute session?
Yes, sir. So next we will have
stick on to the time.
Panel.
10 minutes
Yes,
panel discussion.
So next we have a panel discussion. I would like to invite Dr. Meenakshi Sundaram as a moderator for this session, and I would like to invite the panelists on the dais, please. Professor Mariappan, sir, please come to the dais, sir. And SK, sir, please, sir. Riya, sir, please come to the dais, sir. Yeah, I really want to run. Mani, Ama, Nanda, sir.
Good afternoon,
Manigan sir.
Almost towards the end of the session, and we will not take much of your time. Elil, 4 members. Manigandan sir. I once again thank you all the faculties for their contribution and the vibrant discussion. This session is about myths about minimally invasive cardiac surgery. In our PG days, we were just studying in textbooks this mix and all. Now it has become a reality. So we have started our practice also. So I would like to ask a few questions to each of the panelists. I will name the panelist and ask the question. They can share, and the other people can add on to it. This question to Dr. Manigandan. What, according to you, what remains the greatest barrier to widespread adoption of mix globally, and how can we overcome it? We talk mix more, but we do less mix. So what is the thing you feel? Why there is a less adoption for mix?
Thank you, sir. Thank you for inviting me for this conference. This will be a general. For valve cases, actually valve and most of the simple congenital defects, mix can be adopted widely, but it's not being adopted because due to various reasons. Initial times it takes a little longer for setup, and the whole team has to get trained, and it's most of the times it's the camera is not being used. The team does not know what's happening inside. So use of camera and involving the others, getting the whole team gets trained towards the adoption of minimal invasive surgery, and they start seeing the results and the early mobilization, and I think that should help us adopting the mix for valve and simple congenital disease. But for CABG, I think as Dr. Mariappan was saying, the most of the cases are like a widespread disease, worse atherosclerotic disease, multi-level diseases. I don't think getting complete revascularization, which should be our aim, whichever may be the approach, we should always aim for the complete revascularization. This hybrid revascularization is being tried, but we are reducing the
number of grafts.
our outcome, but CABG's results by adding on the stents to the surgery. That's what I feel. So with the time, probably we'll have to, when you are starting, we have to start with, if we are lucky enough to get some single and two vessel disease, at least anterior grafts, then we can slowly step on to the multi-vessel diseases.
Okay, sir. Thank you very much. You have highlighted correctly the blocks to our path. And next question to Dr. Riaz. Beyond anatomical suitability, what key patient factors we can consider for mix versus stenotomy? So, for example, multiple patient comes with multiple comorbidities or obese patient. So, apart from you are planning a case, you can plan either mix or open. Apart from anatomical suitability, what patient-related factors these factors this patient has, we can go for mix rather than open.
Usually,
so this subset of patients will benefit
from mix.
With mix rather than open.
Usually, younger individuals. What we prefer is younger individuals. Usually, due to cosmetic purpose, we go in for mix.
Okay.
Anything else?
Any other
comment on? Have you got any ideas?
as he says, for younger individual goes for, cosmetic reasons, but for even for older patients, for early recovery, we can adopt mix.
Yes, yes.
That will be I will add this point
Yes.
also.
And hybrid approaches. How can hybrid techniques expand the scope of mix? As Manikandan sir was telling, for CABGs and all, it is very difficult to adapt a mix. So how can hybrid techniques expand the scope of mix for complex cases like multivessel coronary artery disease? This question to Dr. Nandakumar.
Sir, first of all, for hybrid approach, we need a heart team approach basically.
Yes. We have cardiologists, we have your institution.
We are having a cardiologist, but nowadays even for straightforward CABGs also, they are not referring for a multivessel disease.
Okay. Oh.
They are trying to do all.
They are studying all vessels.
They are trying to manipulate all vessels. They are not referring even left main and multivessel disease directly to us. They are trying to manipulate something, and then if any complication happens also, they are referring now.
Okay.
But basically, we need a heart team approach for a hybrid thing.
Okay.
We don't have that thing in government setup, I think.
Okay, okay. Any other alternative opinions?
Actually, both the people are yearning, that's all.
Okay, sir.
We are struggling to put RCA and PDA grafts by mix and all. So cardiologists, what they deal with us is, we will put RCA graft or PDA graft, you do the LAD and all. That way they are having some tie-up and managing the case outside. Okay. As he told, we need a cardiac team, that's all.
And
actually, hybrid approach helps in beginning stages because we can get the confidence of the cardiologists, and they can involve. We can involve us more. They'll also it'll encourage us to work as a team.
Yes, yes.
Because otherwise they'll refer and then they forget about it most of the time. Some of the cardiologists follow, but most of them don't follow after what happens after they refer to us for surgery. If you are doing hybrid, it encourages the team approach. The development of the team, as he's saying, lamenting that teamwork is not happening, but this is maybe a starting point for the team to work well in the future. So that will be
your point is well taken, correct. So hybrid, as Nandakumar's problem, Manikandan has given a good solution.
Actually, you can talk to them more and you can get more referrals from them.
Give and take policy.
Yes.
We are working in a government setup, sir. We are most concerned about costs also and also value. How do we address cost concerns? For example, robotics, minimally invasive and all, definitely is going to cost higher. While demonstrate how we are going to overcome the cost factors associated with mix. Manikandan also was telling high definition camera we will be able to mix. How to overcome these cost factors for mix in the initial settings?
Actually, in the year 2007 itself, I did mix CABG. That time I got single vessel or PDA we put. In fact, we need partial clamp. We don't have.
Okay.
Actually, I packed and get it from private hospital and operating. Even now, it is nearly more than 15 years has gone. Still, we couldn't increase the number of cases, number one. Number two, at that time itself, I bought arch and mixed instruments and all, but since it is a fine instruments, we couldn't allow everyone has to handle. And our handling also differ. So we couldn't improve with our own colleagues, number one. Recent times, I did mix MER also. Initially, I was hesitating. I want not pusher, everything this and that. Actually, I spent money from my packet and bought and something from the department fund itself. But at last, actually, Jayaprakash is here only. He used our own retractor. Our regular LA retractor we used. And we simply try with the finger nuts. So we get selection of cases is more because we selected thin patients, not a bulky fellows, and that we managed. not a government institute does not having the money. We have to organize.
Yes.
And the thing is, we felt that we have to buy this many instruments. Even if we ask company people, Fellings, if we ask, they told clearly, sir, these instruments are not needed, sir. Few instruments only, if you have this instrument. In fact, after doing AST, MER and all, I felt it's nothing. And if Jayapras also felt it is nothing,
Yes.
because he only assisted the case. And we used with our own instrument and done the job. So we have to take effort and commitment, that's all, and mindset.
Yes.
That is more important than the equipments and all.
Thank you, sir. We can add more and more questions, but due to time constraints, I am concluding the session. And
Sir, I would like to invite the panelists here, sir, for the photo session.
all the faculties will join together for a joint photo session. Then
Speakers.
some may be leaving, so I want
Vignesh.
Vignesh, vaanga.
Shivan, sir.
Shivanraj, vaanga. All the assistants, எல்லாமே வாங்க.
ரஞ்சித் சார் எழு நம்பி சார் அப்படியே வாங்க.
Post graduates, all can join.
பெரிய ஆட்கள் பக்கத்தில் நிற்போம். கோட்டு பக்கத்தில் நிற்போமா? உட்காந்துடலாமே.
Thank you all. Thank you, panelists. I would like to invite the Merrill presenter. So now, we have a presentation by Merrill representative, Mr. Shibi Doraisamy, on performance of bileaflet mechanical prosthesis for mitral valve replacement.
Hi, so good afternoon, everyone. First of all, thank you so much for giving me this platform to present on the behalf of Merrill Life Sciences. I would like to extend my gratitude to Dr. Meenakshi Sundaram for organizing this CME. So not taking much time here, I would like to just give a brief about our valve portfolio along with what clinical trials which we are running here in Merrill Life Sciences. First, Merrill is established in year 2006 with a vision of expanding its footfall in healthcare segment. And we work across many divisions like cardiac surgery, endosurgery, cardiovascular, diagnostic products. And we also have our own dedicated R&D team in which we have somewhere around 200 plus products in the pipeline all across the Merrill, and somewhere around 20 products of cardiac surgery alone. Infrastructure wise, we have 180 acres of land in Vapi in which we have 3 to 4 plants, and we have recently inaugurated our world class plant which will cater the needs, global needs for the upcoming 10 years. We also do have a Merrill Academy in Vapi along with 12 Merrill Academies all over the globe. Recently we have inaugurated our Merrill Academy in the Frankfurt Airport, Germany. So the vision with the Merrill Academy which we have is to skill enhancement of the medical fraternity along with bridging the gap between the industry and the medical fraternity. Now coming to the Merrill prosthetic valve portfolio, we have our brand name as Miltonia, which is a bi-leaflet valve, and we have 3 types of valve. First is our regular Miltonia aortic, our Miltonia mitral, and we also have our advanced performance series known as Miltonia aortic AP. So this AP series comes with 16, 18 and 20 sizes of valves, giving the equal EOA, like for the 16 valves gives the equal EOA of 19 mm valve, 19 mm regular valve. So in the case of small roots or where the annulus is really small, this 16, 18 and 20 can be implanted easily and getting the higher EOA. We have the valve is made up of pyrolytic carbon, which guarantees excellent biocompatibility and superior safety. We have 85-degree opening angle, which provides the laminar flow throughout each beat. We do have open pivot design. So this open pivot design, the benefit of open pivot design is there are some convex hinges. The hinges is in the shape of convex in which leaflets are suspended outside. So it will help in the passive washing with every beat, reducing the chances of thromboembolism in the cavities. Our carbon rim is made up of pyrolytic carbon with a titanium reinforcement ring. This is a rotatable valve before the implantation. So you can easily rotate and put it in the anatomical or whichever position is suitable for the patient. And our sieving ring is made up of polyester. So this is how what I was talking about, the open pivot design. This convex hinges comes out from the carbon rim where our leaflets are suspended, providing the passive washing. Now I would like to talk about the Miltonia study. We have recently published the Miltonia study. It is a 6-month follow-up study. It is the initial phase of the follow-ups. It was done by Dr. Nitin Kashyap from AIIMS Raipur Hospital. Single center hospital for mitral implants only, mitral valve replacements. 50 patients were included in this study, and the objective was study to evaluate the performance of Miltonia in the mitral position. There are some inclusion and exclusion criteria as well, like both males and female patients are included. Predominantly female patients are there. All patients are more than 18 years with a mean age of 38 plus minus 9 years. And also the patients who are going to undergo MVR surgeries along with or without the tricuspid valve repair. So post-operatively, we have done the follow-up at the time of discharge, 7 days, 1 month, and after 1 month, every month follow-up was done in the study. So patient profile, if I'll talk about, 35 patients are diagnosed with severe MS, while 8 patients were diagnosed with severe MR. There were additionally 7 patients who has severe MS along with the tricuspid valve disease, in which tricuspid repair has been done. 47 patients out of 50 is of rheumatic nature, while 3 patients were being degenerative in nature. As you can see in the table here, all sizes of valves has been used in this study so that we can see the performance of all the sizes in mitral position. So talking about the peak gradient, so the safety endpoints which we will talk about here is the gradient and NYHA class improvement. So first we will talk about the gradients. Our peak gradient after at the time of discharge and 6-month follow-up is significantly improved in every size. So with the p-value of less than 0.001%. And also for the mean gradient has also been improved with the same flow, and patients have seen improved in the NYHA class. So earlier approximately 96, more than 90% were 90% of the patients were in class 3 and class 4 of NYHA class, and post surgery they came into under first and second class. In the 6-month follow-up, what we have observed is there is no cases of prosthetic valve endocarditis or structural and non-structural valve deterioration. 4% mortality rate was there, which was due to PHVT. Patient were diagnosed with the PHVT. So we have identified that one leaflet was not working because of which was seen in the echo as well as confirmed with the fluoroscopy as well. But the reason for these 4 patients were also mentioned in the study, which is they were not taking oral anticoagulants properly, and when they were admitted in the hospital after the surgery, the INR level was somewhere around between 1 to 1.4. So this is the reason for the PHVT. There is no case of prosthetic valve structural or non-structural deterioration. Now coming to the bioprosthetic portfolio, we have 3 kinds of valve in bioprosthetic. First is Daffodil Neo, second is Daffodil, and third is our Flomero. Daffodil and Flomero both are the same valves, but to cater the needs of the patients who comes under the scheme, so we have introduced this Flomero valve. So more or less everything is same in Daffodil and Flomero. The advancements, what we have done in the Daffodil Neo is, we have reduced the total profile height, which means the ventricular protrusion has been reduced in the mitral valves of Daffodil Neo. Second, we have also reduced the sieving cuff diameter in the Daffodil Neo, providing the enhanced DOA as compared to the same size of Daffodil valve. We also provide long holder handle in the sizer set for MICS cases. And on the prescription basis, we also have 17 size. Only Daffodil Neo comes with the 17 size in the bioprosthetic valve. With good EOA. For an example, if I'll talk about 17 size, the EOA is 1.69, and the implants which have done already in all over pan India, the gradients are very good, as close as to 19 mm and 20 mm gradients. The predictors of performances, 3 leaflets are there. All the 3 leaflets are laser cut, which provides the exact same bioavailability. Same shape and size of the leaflets, providing the proper coaptation. Triple frame design to provide the strength to the valve. Also, the valve is treated with the anti-calcification treatment. We have our own proprietary anti-calcification known as Antica. It contains 3 types of cocktail of reagent. First is the denaturing agents, which reduce the bioburdens and phospholipid load. We also do surface active agent, in which the phospholipids are removed from the deep intracellular spaces, and treatment with the cross-linking agents, which prevents the linkage of calcium ions with on the leaflet. So as I mentioned earlier, Daffodil and Flomero is the same valve. We are running many clinical trials in India as well as globally for the Daffodil one. So on the Daffodil valve, the most important trial which we are running is Daffodil 1 trial. It is done on the Indian patient. It is a prospective multi-center clinical study in which 136 patients has been enrolled all across the 19 centers in India. In this aortic valves, we have taken 67 patients of aortic valves, while 69 patients of the mitral valve. With key safety endpoints will be the MACE, all-cause mortality, myocardial infarction, and stroke. The patient enrollment and follow-up is done like 1 month, 6 months, and after 6 months, we have done every year follow-up for the patients. If you can see here, this is the aortic values of the aortic hemodynamics. The mean gradient is gradually decreasing across the years, while the EOA has been significantly improved throughout the follow-up of the 5 years. In the mitral position also, the mean gradient is nearly constant, which while in EOA has been improved after the 4th and 5th year of the follow-up. We have published our first year clinical trial on daffodil, first year follow-up in 2020, and recently published our 3 years follow-up in the frontiers of cardiovascular education. We have done our 5 years follow-up. We have completed our 5 years follow-up of all the patients and submitted the study to be published in the Indian Journal of Cardiovascular and Thoracic Surgeons. Along with that, our first patient in which daffodil was implanted, it was implanted in January 2018. So that patient has completed his 7 years. Last follow-up was done in the January 2025. It was in the center in Ahmedabad. So that patient is doing really good, and we are progressing with doing a patient testimonial, which I will share soon with all of you, that what are the results of this patient as well. Other than this, we are also running some global registries, like in European Union. Our daffodil and tissue valves are also CE marked valves. So we are exporting our valves in the European countries as well. So we are doing some prospective and retrospective registries in Europe, in Brazil, in Kazakhstan. And some doctors are doing, some surgeons are doing their own single center self-initiated trials on our daffodil. Like in last ISCTS, we have presented the data of Dr. Batrinak, who is from Moldova. He is doing his own independent trial on daffodil 1, which is done on 200 patients. He has 2 to 3 years of follow-up data with him till now, and he is going to do this 10 years data as well. So including all this data, we are also planning to do a global registry. So it will help to take more proper and efficient decisions in the favor of the patients. Thank you.
Yeah, the last few slides now, you have told like the effective orifice area increases in your study after 3 to 4 years. How does the effective orifice area increases if it's going to be a fixed valve?
Sir, over the period of time...
you showed 2-3 slides
yes.
before. You said like the effective orifice area of the valve is increased in a follow-up after 3 to 4 years. The valve is a rigid and fixed valve. So the effective orifice area remains the same. But how do you justify saying that it has been increased after 3rd year or 4th year of implant?
It's the mean value of the EOA, sir. So the average values differs from slightly in the pointers. It's a mean value, not the exact value, sir.
No.
Yeah.
You only said like the effective orifice area increase after 3 to 4 years. That is a wrong inference. I mean, before I say it's wrong, I don't know what you are implying. Effective orifice area will not change because it's a rigid, it's a fixed one, right? So it should be a fixed one. It cannot be changed. The gradient can change. The gradient changes is different from the effective orifice area. Thank you.
Thank you so much, sir. Thank you.
So can we conclude this session, please? Thank you, sir. So next, I would, I would invite Meenakshi sir to come on the stage, please. Since all sessions are over, we would like to felicitate our speakers, panelists. So I would like to invite Maripan sir. Sir, 5 minutes, sir. Mudichirlang, sir. Meenakshi sir will felicitate Maripan sir. Next, Manigandan sir. Mani sir. Sir, I would like to invite Maripan sir. So, you felicitate pannu sir at the speakers. Sir, Abhi. Yes, sir. Thank you, sir. அடுத்து இல்லை சார் ஷீல்டு அண்ட் சர்டிஃபிகேட்ஸில் சிவன் சார் சார் சிவன் சார் இன்னும் முத்துவிஜயன் சார் வர முத்துவிஜயன் சார் சார் ஷீல்டு சர்டிஃபிகேட்
அவர் சார் தான் உங்களுக்கு கொடுக்குறாரு.
நான் உங்களுக்கு போடணும்னு கேட்டுட்டு இருந்தேன்.
சார் வந்து உங்களுக்கு கொடுக்குறாரு. அடுத்து யாருக்கு?
சார் முத்துவிஜயன் சார்
அதுக்கு அவர் தான்.
Maripan sir will felicitate Muthujan sir. Thank you sir. Muthu sir, நீ தான் சார் கொடுக்கணும் சார். இல்லை
அவரை கேப் எடுக்க சொன்னேன். கேப் போட்டுக்கிட்டு I invite our RMO who has just now arrived towards second.
So next, we would like to invite Nanda sir.
சிவனை கூப்பிடு.
சார்
சிவன் தான் கூப்பிடு. சாரை கொடுக்குறா. சரி சாரை கொடுக்குறா.
Nanda sir முடிச்சு சிவன் சார். So Merrill presenter.
சார் சார் ஹலோ இல்லை சிவன்ராஜ் எல்லாரும் அடுத்தது சரி யாருக்கு
மெரில் பிரசண்டருக்கு நந்தா
மெரில் பிரசண்டர் கொண்டு வாங்கம்மா. சரி கொடுங்க, அப்புறம் மாற்றி கொடுங்க. அப்புறம் மாற்றி கொடுத்து பரவாயில்ல கொடுத்து நானே அனௌன்ஸ் பண்ணிட்டேன். Sir, I invite our beloved RMO sir to felicitate our one. Dr. K.S. Saravana Krishna Raja. நீங்க அவர் ப்ளீஸ் சொல்லிட்டீங்க அவர்கிட்ட சொல்லிட்டீங்க. சரி சரி அடுத்து பார்த்துங்க. அதுக்கு நான் அனௌன்ஸ் பண்ணுறேன், ஒன்றும் பிரச்சனை இல்லை. ப்ரொஃபஸர் நந்தகுமார் சார் நெக்ஸ்ட். சார் அவருக்கு இல்லை நான் கொடுத்துட்டேன், நீங்கள் கொடுங்க. I invite Shivanraj to come to stage to felicitate. Nandakumar sir, Nandakumar. ரெண்டு பேர் கொடுக்கணும், விக்னேஷ். Dr. Shivanraj sir now will felicitate Dr. Vignesh Kumar. Dr. Shivanraj will felicitate Dr. Elilan, the Master of Ceremony. Next, vote of thanks from Dr. Rakesh.
Good afternoon to everyone. It is an honor and privilege to stand before you today to deliver the vote of thanks on behalf of this organizing team. This CME program, a glimpse of advances in cardiothoracic surgery, has been a remarkable journey of learning, collaboration, and inspiration. And it is my pleasure to express our deepest gratitude to everyone who contributed to its success. First and foremost, I extend our heartfelt thanks to our esteemed Chief Guest and Director, Mani Sir, for gracing this occasion with your presence and sharing your invaluable insights. Your words have set the tone for this event and reminded us of the importance of innovation in our field. To our distinguished faculty members, Kumar Sir, Thalavai Sundaram Sir, and all the speakers who enriched us with their expertise, and I also thank for your enlightening presentations and for fostering meaningful discussions. Your contributions have elevated the knowledge of every participant here today. A special note of appreciation to our dedicated organizing team, Meenachi Sundaram Sir, Ellen Sir, Abhinaya Vallaban, Vivekanand, and Anand. Your tireless efforts, meticulous planning, and unwavering commitment have made this event a grand success. I also thank staff for ensuring that work ran smoothly. On behalf of the entire team, I thank everyone for making this event a memorable one. Thank you one and all.
I request all of you to join for the lunch, and we also have another enlightening session in the evening. Anybody wants help for travel, you can contact Dr. Elilan, and the evening session starts at 6. I once again request all of you to join for the evening session also.
Yeah, if you have requested for a transport, if the transport facility is available, you can flash it on the PowerPoint.
Sure, sir. Sure, sir. By lunch, we'll. Sir, sir, I would like to invite. Sir, one second. I'd like to invite Maripan sir and Meenakshi sir on stage, please. Maripan sir will felicitate Meenakshi sir. Yes, sir.
Really done very good job within the short period. He himself come forward without any hesitation and ego, and organized well, and program also went off well, and healthy discussion also went off well. Congratulations.
Thank you, sir. Thank you, sir. Thank you, sir. So we'll adjourn for lunch.